Okay, good evening, good afternoon, everyone, and welcome to the first roundtable meeting on neck dissection. And greetings from Mahamana Pandit Madan Mohan Malvi Cancer Center. So before we start, I would just like to brief everyone what is the purpose of having this roundtable meeting. So this meeting is being organized on the World Head Neck Cancer Day, and the idea of holding this meeting is that in India, we have varied practices. And with so many institutes, we still have certain guidelines. But alone from India, we do not have any guidelines that guide us that this is the standard of care that we're going to follow across all centers. Yes, there are very good centers, there are very good people, there are very good surgeons that are practicing. But we are coming here together to form a consensus on various small questions, right from what imaging do we do? Shall we do a USG? Because sometimes we have a USG scan, sometimes we have a CT scan, sometimes we have a MRI imaging, and various other modalities. And to sort all those questions, how to evaluate, how to work up, what should be the extent of surgery, whether we are going to use sentinel node biopsy, avoid a neck dissection, or just continue. So based on that, we have created certain guidelines, and on those we are going to discuss today. And as we proceed, we are going to share those points so that we are able to discuss specifically on those points on neck dissection. And I have a request from all the participants, the attendees, they may not be able to speak directly, but they can raise their hands, and we'll allow them to talk, and they can join in for the suggestions as well as for discussion at that time. So I'll just briefly show what points we are going to discuss upon. So there will be 4 sessions. One will be on the conventional neck dissection, that will be evaluation and the treatment nape neck. Then surgery, what type of neck dissections, the type of and the extent of the surgery. Then is there any role of elective neck irradiation, when to address the contralateral neck, the role and how we are going to plan for the adjuvant treatment. And the role of the sentinel node biopsies, whether we are going to use it for all cases, how we are going to develop it for the future, and is sentinel node biopsy going to be the future of neck dissection? How we are going to perform step serial sectioning for those, how we are going to pathologically evaluate those necks. Then the newer technologies, how minimal access approaches for the neck dissections are being developed, how the robotic and the laparoscopic assisted neck dissections are being performed, and whether they are going to be the future in the next 10 to 20 years. And then whether our treatment modalities and the follow-up modalities and the imaging modalities change the way that we are going to follow up our patients in the coming future. So this will be the agenda for the meeting today, and I welcome you all for a very good and a great discussion. So I think we'll be starting for the first talk.
Yeah, hi.
And he'll be discussing on the present scenarios of management of the neck dissection.
Right. Asim, is my screen visible?
No, your screen is not visible.
So yeah, I'd like to wish everybody a very good afternoon. And on this occasion of World Head Neck Day, it is a great initiative taken by Asim and the entire team at Mahamana for trying to develop a guidelines or a consensus statement on the management of neck. So as we know that the presence of a nodal metastasis is actually it reduces survival by 50%. And I think we can just ask someone to go ahead with the slide. Yeah. So as we all know that in the presence of nodal metastasis, it reduces survival by 50%. And the presence of extracapsular spread further reduces survival. And hence, management of neck is indeed of utmost importance in achieving local regional control and ensuring proper survival of our patients. In this brief talk, what I would like to basically highlight is the practices that are right now, that whatever guidelines that we are following. So in brief, the patterns of nodal spread, the imaging for the neck, the need to address the N0 neck, the extent of surgery for N0 neck, and the extent of surgery for the N plus neck. So staging the neck appropriately, and why it is important. Clinical examination, as we know, is inferior to any imaging modality. This was a meta-analysis by Merit in 1997, and they showed that the accuracy of a CT scan was significantly higher than that of a clinical examination alone. At the max, you will be able to estimate only 60 to 70% of non-mechanical examination. Hence, the need for an imaging tool. This was a meta-analysis by DuPont, a meta-analysis of 17 studies, and they created a lot of interest in the USG guided FNAC, showing that the diagnostic odds ratio was maximum for this modality. However, it is important to note that this meta-analysis per se included studies which looked at N plus nodes as well. And this is not what was seen in other studies, especially this study by Saurabh and Sir, who looked at the role of USG guided FNAC vis-a-vis sentinel node biopsy, keeping gold standard as HPR. So a series of 51 patients prospectively all underwent USG neck to confirm N0 status, and in case there was an indeterminate node, they underwent USG guided FNAC. All patients also underwent a sentinel node biopsy followed by a neck dissection, so that the comparison of USG FNAC to SNB could be done. And very interestingly, they found that the sensitivity of USG guided FNAC was as low as 14.3%, although it had very high specificity, positive predictive value and negative predictive value. But the sensitivity per se, what we thought was very high, was actually found to be very low in this study. Liao et al. Again, this was a meta-analysis including multiple imaging modalities, including only N0 neck, and their results show that the sensitivity more or less was similar whatever imaging modality used, but CT had better specificity amongst all. Here again, we had another study led by Chalker sir, who compared ultrasound, CCT, and PET CT in a series of patients at TMH, and they also found that although most of the imaging modalities have a comparable outcome, but the diagnostic accuracy of CCT is higher for an N0 neck, even higher than that of PET CT. Now, the imaging of the N0 neck is, do we need a particular imaging modality? No, because in spite of rigorous preoperative workup, there will always be 20 to 30% of occult nodal metastasis. And more so, if you look at the results of the SCENT trial on SNB, where despite extensive preoperative workup, which included a CT and or MRI, and an added USG guided FNAC in the presence of a suspicious or indeterminate node, the diagnostic workup failed to detect metastasis in as high as 23% of patients. Also, indicators like depth of invasion are not available preoperatively to the clinician. So although it was thought that imaging of the neck in a patient with oral cancer is necessary, but today what we normally follow is that the imaging modality is based upon the primary tumor, that is the buccal mucosa or the tongue. So the N0 debate scenario, where we have no debate actually on larger lesions, T3, T4 tumors, and even in T1, T2, wherein the neck is there in the field of treatment, for example, raising a cheek flap like during surgery, we must address the neck and do an elective neck dissection. So which is the debate scenario per se? T1, T2, per oral dissection is possible, and the neck need not be validated for surgical treatment. This was the debate scenario where we had a ongoing debate of END versus observation. If you go to the next slide, in the proponents of END, we had like better survival. It dealt with occult metastasis and it could guide adjuvant therapy. And those who proposed observation said that because the incidence is only as high as 20 to 30%, so it can spare neck dissections unwanted in 70 to 80%. There were multiple randomized trials. If we go to the next slide by Fasunla et al., this was a meta-analysis of the existing 4 randomized trials on elective neck dissection, and what they actually found, they made a confirmation that yes, elective neck dissection does have a benefit if you looked at the relative risk ratio. However, in a much detailed analysis of this particular meta-analysis, Dr. De Cruz et al., they actually showed that this meta-analysis was not without shortcomings, and in a very nicely summarized paper, they have highlighted the points showing that what are the fallacies of the Fasulna meta-analysis, basically inadequate numbers to provide survival benefit. And again, out of the 4 randomized trials at that point of time, only one of the 4 individual studies, that is the Kligerman study, showed survival benefit. And if you remove this particular study, the hazard ratio was not significantly different. And of course, there was a lot of heterogeneity, and it outlined the need for a well-powered large randomized trial. And this was provided by the N0 randomized trial led by Dr. De Cruz. It was published in the NEJM in 2015. And it was presented by Sir at ASCO. So on the next slide, we have the trial design. So early oral cancer patients, node negative, squamous cell CAs, these were randomized into 2 arms, selective neck dissection and wait and watch approach. They were further more randomized into a second randomization of physical examination and versus physical examination with an ultrasound neck. And this, I think, this topic will be spoken about by Dr. Richard in subsequent talk in the next few hours. And results, as we all know, overall survival 80% versus 67%, 12.5% overall survival benefit in the END arm, and also that was seen in the DFS. So this kind of, laid the background that yes, an active neck dissection is necessary in early oral cancer node negative patients. And multiple meta-analysis and systematic reviews have followed, all supporting the same. There has been another randomized trial, the SEND trial, done in the UK. And this was performed in a multicentric manner across multiple centers within the UK itself. And 250 patients were randomized. And not just they had a randomized cohort, they also had an observational cohort of 346 patients. And overall results were in the favor of the elective neck dissection arm again. And interestingly, in their study, they also showed that END had a DFS benefit for T1 tumors, which was actually not so significantly seen in the N0 trial at TMH. So both these randomized trials together, and then they also performed a meta-analysis comparing all the earlier randomized trials as well as the SEN trial, and an OS and DFS benefit, showing in favor of an END. So an end to the debate that yes, elective neck dissection is necessary in T1, T2, N0 oral cancers, and a summary of the ASCO guidelines, as we can see here. Recommendation 1.1 that CT2 to T4 CN0, they do need an ipsilateral elective neck dissection. The ASCO guidelines have made one particular caveat, and they have said that where can we wait and watch in select patients of CT1 where close surveillance may be offered by a surgeon in conjunction with specialized neck ultrasound. Again, this has to be very tailor-made, and probably this can be followed up in a patient, for example, a patient who presents to you in your clinical practice where already underwent a wide excision of a T1 oral lesion. The neck was not addressed, probably an excisional biopsy with margins. And if we find that the depth of invasion was, hardly 1 to 2 millimeters, it is a highly compliant follow-up. There, explaining the pros and cons, one might offer the wait and watch approach. But again, in an upfront setting, END is advised even in the T1 subgroup. And what is the extent of elective neck dissection? They have said that levels 1 to 3 elective neck dissection is adequate as long as we are removing 18 lymph nodes. There have been multiple studies, especially from Australia, from Jonathan Clark's group, which have laid the basis for this particular number of 18 neck nodes. In the next slide, I've kind of just tried to mention in one single slide the patterns of cervical lymph node metastasis from oral cancers. This was a seminal publication of Dr. J.P. Shah and Candela, back in 1990. And if you look at the box in the red circle, so they divided their patients into three groups: selective R&D, immediate R&D, and subsequent R&D. I'd like to focus on level 1 to 3 and look at all the three rows. Majority of our lymph node prevalence was in level 1 to 3, with level 4 metastasis only in 3%, and level 5 was seen for maybe floor of mouth primaries in less than 1% or 6% in the intermediate neck dissection group. So this was the initial study that laid the background for, why level 1 to 3 or level 1 to 4 neck dissection is adequate in an oral cancer patient, even if it's N0. Again, we have the results of a prospective trial. This is a Brazilian trial, 148 patients, T2 to T4 N0, oral cancers, and they showed that the 5-year actual survival rates between the MND group and the SND group were very comparable, and more number of complications in the MND group, again stamping the case for SND is enough in an elective N0 scenario. Now, the management of the node positive neck, I will try to finish as fast as I can. Management of the node positive neck. Why we are so concerned is because whenever we address the level 5, there is a lot of morbidity, shoulder syndrome, injury to the spinal accessory nerve. Hence, we try to find scenarios where can we avoid level 2B and level 5 neck dissection. Is that possible even in an N plus neck? So this was a prospective study of 583 neck dissections in oral cancers led by GP ma'am, and what they did was they sent all the individual nodal levels separately in separate packets, as can be seen over here, and prospectively each nodal level was found out, and so. What their results were that lymph node metastasis in oral cancers mainly concentrated in 91% of cases in level 1 to 3. If you add level 4, that will account for almost 96% of your metastasis. And the incidence of skip metastasis to level 3 was 7.3% overall, slightly higher in tongue cancers. There were no isolated metastasis to levels 4 and level 5. Now, let us go to the predictors of nodal metastasis with respect to level 2B. Overall incidence was 3.8%. 2B nodes were always associated with the 2A, or more often than not associated with the level 2A node in 65.7%. So level 2A node presence was significantly associated with 2B metastasis. And similarly for level 5 also, although the overall incidence was 3.3%, but then 2A positivity was significantly associated with level 5 metastasis. So level 2A nodes becomes one of the strongest determinant for 2B and 5 nodes, and can be regarded as a determinant for tailoring your neck dissection. Now, this was another meta-analysis published in 2015 in Oral Oncology by Liang et al. 443 patients, where they looked at 5 studies comparing SND versus MND in node positive neck and found no significant difference. However, here I would definitely like to add that in the presence of multiple neck nodes or multi-level neck nodes, in the presence of extracapsular spread, definitely even today MND is still considered the standard of care. Now, contralateral neck will be spoken about by Dr. Akshat, and this was again a talk. A paper from TMH by Sudhir Nair and Vikram sir, which basically said that in the presence of multiple ipsilateral neck nodes and the disease reaching or crossing midline, the contralateral neck has to be addressed. So the extent of neck dissection, the key points would be for the N0 neck, selective neck dissection has similar outcomes to MND, and today for an N0 neck, you must address the neck. Levels 1 to 3 and level 1 to 4 suffices for an N0 neck without a level positivity. For those with level 2A positive neck nodes, level 2A, level 5 need to be addressed. And in the absence of ECS and multi-station nodes, level, if we have a node in level 1A and 1B, performing a level 1 to 4 neck dissection may suffice in an N plus. And with that, I would like to thank you, and over to Akshat for the next talk.
After the talk of Akshat, we are going to have a discussion on the conventional management by Devendra sir. So Akshat, are you please share your screen?
Seeing and the rest of the members of the group. And lovely talk Hirsch, where I think he's nearly got everything that is talked about. I will talk about measurement of and recurrent neck disease. Now, unlike a lot of evidence which Hirsch showed, spondylolisthesis and recurrent, a lot of evidence is low and still evolving at certain levels, I would say. We would be covering initially the chondrolateral neck, and later on we'll be talking about the recurrent cancers, neck dissection for recurrent cancers. So, as majority of you would be aware that if there's any lesion, as per general consensus and also as per ASCO guidelines, which like Harsh was talking about some time back. So if any lesion is crossing midline or involving both sides of the oral cavity, then of course we'll be addressing the opposite neck. There's no doubt about it. But the question comes when it is reaching midline, or it is just short of midline, or if it is a localized tumor. So that is what we'll be concentrating on today. Now, in this picture, you would see that one half of the neck is dark and the other half is lit up. So similarly, the two sides lymphatic drainage is different. Now, many times it is assumed that if level 1A node is involved, then we need to look at the opposite neck, because that means the nodal drainage could have gone to the other side also. So in certain cases, we tend to do this. We send level 1A for frozen section, and based upon whether it is positive or not, we may decide whether we want to do the opposite neck. This is for lesions which are just reaching midline or are just short of it or just across. But then there's no good evidence to support this, though I believe many of us do practice this. Harsh had shared this slide previously, and this is paper by Dr. sir, where we have looked at cases with tongue cancers who are reaching or just crossing midline. Here they found that contralateral nodal metastases were there in 29% of cases. So about a third of them may have contralateral nodal mets. And out of those with contralateral nodal mets, 97% had ipsilateral nodes. So predictive factors for contralateral nodal mets were patients who were having ipsilateral node positives. So these were the patients who were expected to have nodes on the opposite side, and they should definitely be considered for neck dissection. Besides this, on multivariate analysis, T size was also found to be significant. Now, you might have heard of SAINT trial. This was a multi-center trial done in Europe over 14 centers. They include 415 patients. And Dr. Thankapan would be covering this later on. But I just want to delineate this fact out here that using sentinel node, they found that even lateral tumors, that is tumors which are just located on one single side, they may drain bilaterally in up to 10%, or they may be exclusive contralateral drainage in about 2.4% of the cases. So this is something which you need to keep in mind. Now, again, this was a very interesting paper where what they have done is they've divided T3 tongue cancer patients into two types, a shallow T3 or a deep T3. Cutoff was 1 centimeter. So as you can see on these Venn diagrams on the right side, the contralateral neck was only positive with deeper T3. So depth of invasion more than 1 centimeter is definitely indicative that there may be nodes on the opposite side. This is especially for tongue cancers. Now, this was another paper where they had again looked at contralateral N0 neck and how it should be managed. They said the risk was high with T3 and above classification, and also for crossing midline or just nearing midline with unilateral metastasis, which we have already covered. They suggested that a contralateral lymph node dissection should be done for these cases, or at least a bilateral radiation should be considered. So bilateral radiation is actually already done for such cancers, for tongue cancers with increased depth of invasion, or for nodes, tongue cancers, or other oral cancers with high-risk features. Generally, bilateral radiation may be considered in majority of these cases. The same group also tried to compare the results in form of they divided into two groups, elective neck dissection, and the other group was observation. They found that elective neck dissection actually did not help out much for small lesions, localized lesions of oral tongue. So early localized lesion, there's no point of doing contralateral neck. this is a very nice review where they've looked at where all contralateral neck should be addressed. And here I would like to focus your attention to this last column, talking about predictive factors. Now here, if you would see, it mentions TNM stage, ipsilateral metastasis, high pathological grading, surgical margins, PNI. So any histological factor you talk about, people have looked at that and they have shown some association with contralateral nodal metastasis. Now, in this study, they looked at failure rates in untreated contralateral nodal node negative neck. So opposite neck was negative, but then it failed. So this was a multi-center study conducted over North America and in several centers at Australia. And they specifically looked at patients with early cancers. So T1 was 68% and majority were N0, and adjuvant RT was also considered for only 17% of patients. So these are the patients for whom opposite side would not have been addressed. So they found that 5-year incidence of contralateral neck failure was 4.3%, which is quite low as you can imagine. And this is for small localized lesions. And on multivariate analysis, they only found depth of invasion more than 1 centimeter to be significant for this. So this is again in lines of what we were discussing previously. This was one of the tables which they are included. The first one is their own study. As you look at few other studies where they've looked at predictors of contralateral nodal metastasis, they are PN plus on the ipsilateral side, poor differentiation, multiple node positive on same side. So like I mentioned, if we list out the predictive factors, so these would include many things and nearly all the histological factors. But major considerations would be, of course, reaching midline, tongue cancers, floor of mouth cancers, multiple ipsilateral neck nodes. These are the major considerations. Now, this study by Christian Doll from Germany, they looked at whether contralateral neck should be addressed in unilateral node positive oral squamous cell cancer. And they found that there was no point in doing elective neck dissection in such scenario on the contralateral side. Risk adapted radiotherapy seems to cover up our oncological concerns which may be there. This was one of the studies from TMH, and I think Manish is also there online. So skin involvement, here we are not talking of tongue cancer, here we are talking specifically of buccal mucosa cancer. So lesions which are reaching midline or just crossing it were included in this. And of 28 patients with contralateral node, 26 had ipsilateral nodes positive also. And predictors of contralateral nodal metastasis were ipsilateral nodal positivity and skin involvement. So extensive skin soft tissue involvement can also change the lymphatic drainage, and then we should be looking at opposite neck. Now, coming on to post-treatment neck or recurrent cancers in the neck. So previously, as you would be aware, post chemoradiation, many people, it was a norm to do planned neck dissection, and then people started going ahead with active surveillance. This was cemented well through PET neck trial, where they showed that there was no difference in overall survival if we are observing these patients through PET, and there were fewer neck dissection in the surveillance group. So PET was found to be good surveillance tool for these patients. Now, why we are talking about this is because several studies, in fact, by Dr. Mehana as well, and from the Dr. Tejpal Gupta. So they have clearly shown that there's high negative predictive value. If the PET tells us that the opposite neck is negative or there are no neck nodes, then that means in majority of cases that there are no neck nodes. But still, this negative predictive value is to the range of 80 to 90%, not more than that. Now, this was one of the abstracts published from radiation oncology group from TMH. Here they looked at contralateral nodal relapse in well-localized oral cancers for whom surgery has been done and radiation has also been done with or without chemotherapy. So 210 patients were included in this, and they found that 10% had isolated contralateral relapse and 4.3% had bilateral nodal relapse. So contralateral nodes would be seen in about 10% of patients isolated. So that means we may still need to address the opposite neck. We cannot really ignore it. Though the magic figure as per Weiss's study comes out to 20%, but these 10-15% patients who come in also need to be considered. This was again another study from TMH, where they showed that addressing the contralateral neck for ipsilateral disease recurrence in oral cancers is important. And contralateral nodes may be present in up to 23%. That is about 1/5 to 1/4 patients may have contralateral lymph nodes, and these may be occult in 14%. So this is very important to consider. You may not say that, okay, PET was negative or other imagings were negative. Still 14% occult nodal metastasis may be there in opposite side. So if the ipsilateral neck nodes have been addressed and we are having a aggressive tumor on this side, it's always safer to do opposite neck. And here also they found that depth of invasion more than 10 millimeter was found to be significant. Now, besides this, I believe Dr. Thankapan will be talking about this. Sentinel node biopsy has also been shown to be of advantage in recurrent cancers. Though the RCTs exist for early oral cancers, but even in recurrent ones, they have found that lymphatic drainage may be seen. So in this study by Flash, you can see that this figure on the left side shows oral cancers, and the number in oblique by the second number is the contralateral nodal metastasis. So you can see that SNB even showed contralateral nodal drainage in patients with oral cancers who underwent SNB for recurrences after previous treatment. And this is even further supported by international guidelines on SNB for oral cancers. Now, as a take-home message, Deepika Padukone is just there for attention. You need to consider upfront contralateral neck dissection definitely for tumors crossing midline involving opposite side, reaching midline with ipsilateral neck nodes, probably with level 1A involvement also. High DOI or T classification may again direct you to address the opposite neck and also skin involvement. Talking about recurrent cancers, PET scan and imaging modalities are important. Sentinel node biopsy has got a evolving role. You should definitely consider ipsilateral completion neck dissection. If you have done a selective neck dissection on the same side and there's a big recurrence out there, you would want to clear out level 4 and 5 because probably that is where the lymphatics will drain to. And coming on to contralateral for recurrent cancers, here, if disease reaching midline or crossing midline, or there's high depth of invasion or higher T classification, it will be safer probably to address opposite neck. But like I said, the level of evidence for this is not that strong, but this is what majority of studies like we discussed do suggest. Thank you. I believe questions would be covered later on.
Thank you so much, Akshat. We'll proceed with the next lecture, and that will be on the newer technologies and the role of sentinel node biopsy in oral cancer. And this will be presented by Dr. Krishna Kumar Thankappan.
Hello.
Hello, yes, sir. So please share your slides.
Yeah, once again, please hold on. Yeah, I hope you can see my screen and I'm
Yes, sir, yeah.
So good evening, everyone. Today I'll be talking on sentinel node biopsy in oral cancers, applications, methodology, and challenges. So as you heard from the earlier speakers, we all know the two approaches earlier for early stage oral cancers in an N0 neck was wait and watch or elective neck treatment. But with this paper by De Cruz et al., there is no doubt about that. We have to do an elective selective neck dissection in T1, T2 oral cavity cancers. So that's the current standard of care. But elective selective neck dissection is not without morbidity. The morbidity can be scar related, shoulder dysfunction, mandibular, marginal mandibular facial nerve palsy, and so on. So we have done this study. Selective neck dissection in oral cavity cancer is not without morbidity. We retrospectively looked into about 100 of our patients. Others show us our first author, and we found poor scar outcomes in about 25% of the patients, lymphedema in 14% of the patients, skin problems in around 10 or 12 patients, facial spile asymmetry, meaning marginal mandibular palsy in 31%, and shoulder dysfunction in about 7.5%. So it's a procedure that is not without morbidity. So sentinel node biopsy is a middle path to stage the neck adequately without the morbidity of selective neck dissection and without compromising the survival outcomes. So what is the concept of sentinel lymph node? The metastasis from the primary tumor occurs by a predictable orderly spread to the first echelon node before reaching the nodes in the remaining lymphatic basin. If the histopathological examination of the sentinel node can be defined, and if it is proven to be negative, we can say that the nodes in the remaining the lower nodal stations could also be negative. So there will not be a need to clear the lower level nodes. So that is a concept of sentinel lymph node. It is a standard of care in melanoma, breast, and so on. And it's also being evaluated in many other tumors. So what are the techniques for sentinel nodal biopsy in oral cancer? It can be used with the help of a blue dye, or it can be a radionuclide based, that is a lymphoscintigraphy based, or of late we are hearing also about an indocyanine green based technique. What are the steps in the procedure? The steps include the preoperative lymphoscintigraphy, intraoperative lymphatic mapping, excision of the lymph nodes, pathological evaluation of the isolated sentinel lymph node, and a neck dissection, either the same day or a staged neck dissection, depending on the status of the sentinel lymph node. So initially, the patient, the day of the surgery, is taken to the nuclear medicine department. They give a peritumoral injection, and technetium 99 labeled sulfur colloid is injected at 3 to 4 points at the tumor periphery, about a volume of 0.1 ml with a total activity of about 700 microcurie, 37 megabecquerel, and imaging is done. Previously, we used to get only lateral planar images, like a lateral and frontal. You can see the tumor uptake and the nodal uptake. And then they used to mark it on the skin, and then the patient is brought to the theater, and we use an intraoperative lymphoscintigraphy. But now we have something called a SPECT CT, that is the use of CT scanners as opposed to the planar imaging. It's a combination with the single photon emission CT, and it helps in the better resolution of the nodes that is adjacent to the primary tumor, where shine through can be a problem. And it also gives a better definition of the nodes relative to the anatomical landmarks, and improved attenuation scatter of the gamma rays also facilitates the localizations. So this is a SPECT CT nowadays, which we get. We can see the primary tumor and the sentinel node. So we can see the sentinel node in relation to the anatomical structures, and then we could localize it easily. As a second step, the patient is taken to the theater, and intraoperative gamma probes are used after making an incision, and the nodes are identified. So it's a handheld gamma probe. There is no threshold radioactivity value. It varies with the time of the injection, the quantity of the isotope used, and the location of the tumor. The node with the peak radioactivity and those with more than 10% of the peak activity has to be removed. The node with the peak radioactivity is the sentinel node, but we also may have to remove the nodes with 10% of the activity. The bed should have the activity similar to the background. Lymph nodes are considered sentinel when the gamma count is at least 10 times that of the background and 10 times that of the hottest node excised. What is shine through effect? It is seen in cases of floor of the mouth lesions and or when the sentinel node is located in the submandibular region or level 1 region. And then we may have a difficulty in detecting the level 1 node due to the intense activity from the primary area. What is the solution? We have to resect the primary as a first step. Still, it is not foolproof. And then explore the level 1. Mostly you will get out the node, and then you take it out and confirm the activity on the table ex vivo out of the patient. So the SPECT CT also will help to localize it very well anatomically in relation to other structures in level 1. And we can also use a combined technique with the blue dye. This is the only place where blue dye may have some role. So what is blue dye? It's isosulfan blue. Sentinel node appears around 15 to 45 minutes after the injection. Disadvantages, it needs visualization and hence full exposure, which is against the concept of sentinel node biopsy. And it is small particle size, so very poor retention in the nodes. Leakage will interfere with margins, and sometimes there can be allergic to the dye. Main point is that it is against the concept of the sentinel node biopsy, meaning that we may need to expose all the levels, even the contralateral levels, to find out the node. And this is the case when it is used alone, but it may have some role because it may help in cases where there is shine through. So the only place where it can be applied is floor of the mouth tumors along with lymphoscintigraphy. Pathological evaluation, again, there are many steps. Intraoperative evaluation, we can do an imprint cytology or frozen section. The sensitivity is around 60 to 70%. Negative predictive value is 83%, meaning that if the frozen section is positive, we can complete the neck dissection on the same day itself. And if the frozen neck is negative, the sentinel node is subjected to routine histopathological examination, including hematoxylin and eosin. Serial step sectioning has to be done. And routine, the H&E identifies one tumor cells in 10,000 normal cells, that is stages up to 10%. Serial step sectioning and immunohistochemistry with the cytokeratin identifies one tumor cell in 1 lakh normal cells, that is an additional upstaging of 10%. And we can also do a serial step sectioning and RT-PCR, which may identify one tumor cell in 1 million normal cells. This last one, the serial step sectioning and RT-PCR, is still in the research stage. It is not clinically applied, but HPE, H&E and IHC can be applied routinely for clinical use. So what is macrometastasis? When the metastasis is more than 2 millimeter in size. Micrometastasis is defined as tumor clusters more than 2 millimeter and less than 0.2 millimeter and less than 2 millimeter in size. Isolated tumor cells are defined as small clusters which are not larger than 0.2 millimeters. The clinical significance of isolated tumor cells are not very well defined. What is the learning curve of this technique? It's usually around 10 cases. It was established as part of a surgical procedure standardization in the surgical trials. Now let's come to what are the literature available and what is the evidence for using sentinel node biopsy in early oral cavity cancers. The literature can be divided into diagnostic efficacy studies, oncological outcome studies comparing it with selective neck dissection, and lastly, morbidity studies. Regarding the diagnostics efficacy studies, there are many single-center, retrospective, prospective studies and meta-analysis, and 3 or 4 meta-analysis are there, and we could confirm the sentinel node detection rate is up to 98%, sensitivity of the procedure up to 100%, and negative predictive value about 99%. So it is a good diagnostic, it has a good diagnostic efficacy. There are many meta-analysis proving a pooled sensitivity of upwards of 90% and negative predictive value reaching up to 96%. So those are diagnostic efficacy studies. So now coming to the oncological outcome studies, comparing with the selective neck dissection. What is the difference between diagnostic efficacy and oncological outcome studies? Diagnostic efficacy studies are single arm studies. So the patient will undergo sentinel node biopsy, and also they will undergo the neck dissection in the same arm, and then the sensitivity and specificity or negative predictive value, all these are calculated. Such single arm studies are called diagnostic efficacy studies, but oncological outcome studies are always 2-armed studies. There are NCDP database studies, 2-armed, and then we have 2 randomized control trials, and we have a meta-analysis of RCT also. Now, coming to the NCDB study, about 8,328 patients, Kramer et al., 3-year overall survival was comparable, 82% in sentinel node biopsy arm versus 77% in selective neck dissection arm, and the difference was not statistically different, but with less morbidity in the sentinel node patients. Now coming to the randomized control trials, the first study was titled Equivalence Randomized Trial to compare treatment on the basis of sentinel node biopsy versus neck node dissection operable T1, T2, N0 oral and oropharyngeal cancer. This is a study from France. T1 and T2 oral and oropharyngeal cancers, 139 patients in the neck dissection arm and 140 patients in the sentinel node arm. It was an equivalence study. They showed non-inferiority, meaning that the outcomes were similar. But one thing to note is the non-inferiority margin they selected was 10%. We'll talk about it in a while. So the 2-year nodal recurrence-free survival was the outcome, which was 90 versus 89, and it was not significantly different. So sentinel node biopsy was proven equivalent or non-inferior to selective neck dissection. Now coming to the Japanese study, Hasegawa et al., neck dissections based on sentinel node navigation versus elective neck dissections in early oral cancers. Here only oral cancers were considered. The previous study had very few oropharyngeal cancers also. Here again, T1, T2, N0 oral cavity, neck dissection 137 patients, sentinel node biopsy 134 margins. Here again, the non-inferiority margin was 12%, and they also could prove non-inferiority, meaning that sentinel node arm could achieve outcomes that is non-inferior to the neck dissection. The 3-year overall survival was 87 versus 86, non-significant. 3-year disease-free survival was 81 versus 78, non-significant. Now, what is the problem with these two studies? It is that non-inferiority margin which they selected, 10% and 12%. Why did they choose 10 and 12% for the feasibility of the study? If the ideal non-inferiority margin that is the best is about 5%. But if they choose 5%, the sample size will be very large. And so the feasibility of the study will be compromised. That is probably why they choose this 12%. But that brings down the quality of evidence a little lower. So that is the main problem with these two RCTs. And we also have this meta-analysis of RCTs done by Dr. Tejpal Gupta from Tata, titled Systematic Review and Meta-Analysis of Randomized Controlled Trials, comparing elective neck dissection versus sentinel biopsy in early stage clinical node-negative oral and oropharyngeal squamous cell carcinoma, evidence-based for practice and implications for research. They considered 3 RCTs. Here I would like to say we were the first. We in Amrita were the first to do an randomized control study. We have not fully put into publications, but there was a small publication about it, and this publication also was taken into the this particular meta-analysis. And Tejpal Gupta concludes that the overall survival difference was not statistically significant, and the pooled hazard ratio was 1.18. Interestingly, the concluding sentence is very interesting. He concludes that there is low certainty evidence that sentinel node biopsy is oncologically non-inferior to elective neck dissection and is associated with a potentially lesser functional morbidity, making it an emerging alternative standard of care in patients with early stage clinically node-negative oral cavity squamous cell carcinoma. So if you read these concluding lines, we can see there are many adjectives used without stating it clearly that it is the best. So maybe the reason may be that which we discussed, the problems with the non-inferiority and so on. So he does not give a clear-cut say that this is the best and that it should be done. Again, if so, what is going on in the US? They have started a trial with the non-inferiority margin. This is a web page from clinicaltrials.go. They have started a trial. The number is this, and the target approval is 616 patients when they take a non-inferiority of 5%. But this part is very interesting. The estimated study completion date is 2036. Okay, that is like 12 or 13 years from now. So that's when we are going to get the results of this particular study. And then the technology would have changed. The isotopes would have changed. The scanning would have changed. So whether we will be able to bring this particular technique into practice in 2036, I am not sure. So that is why we have applied. What is Amrita? What are we doing at Amrita? So we were as I told previously, we were the first center to do a randomized control trial, but that trial we started in way back in 2003. But that had many limitations because of our small sample size, lack of power, and definition of N0 neck. We were, for the 2/3 of the patients, we were using just clinical examination to define N0 neck, and that was not good. Finally, we have also had few T3 tumors. So all these were creating problem, and it was actually a negative study. And then we also have published the pathological data of 80 patients. Dr. Neerav Trivedi is the first author for that paper. And this is the small paper published by our nuclear medicine team, which has brought out our oncological outcomes. Now, with the after that initial attempt, with this emerging evidence from RCTs from these two trials and Tejpal Gupta meta-analysis, now we have adopted it for T1 and T2 tumors since 2019. And we follow AJCC 8th edition to include patients into this approach, meaning that we include tumors less than 4 centimeter in grade and dimension and less than 10 millimeter thick on MRI scan. And there should not be any suspicious nodes on MRI scan and ultrasound neck as reported by an expert radiologist. So MRI scan and an ultrasound scan and a reporting by an expert radiologist that there is no nodes that is suspicious, as well as the thickness is less than 10 millimeter is an absolute essential for including the patients in this study. And we do it as a standard of care. It is not a research. We do it in all patients if they satisfy this criteria. Till now, we have done it for 46 patients from September 2019 to July 24, nearly 5 years. The mean age of the patient was around 60 years, males in 24, females 22. Clinical and radiologically, T1 and T2, N0. AJCC 8th edition. We have tongue 45 patients. There was only one buccal mucosa patients. The mean depth of invasion on the MRI was 7.1 millimeter. Clinically T1 patients, clinical radiological, I mean, was 38 patients out of 46, 82%, and T2 in 8 patients. And level 2A was the most common level of sentinel node in 73% of the patients, that is 34 patients. There were contralateral sentinel node in 5 patients. This is an important point to note. We could identify contralateral sentinel node in 5 patients. And finally, on pathologically, it was T1 in 73%, that is 34 out of patients, and PT2 in 6 patients. PN0, nodal status was 45. Only one patient had a sentinel node that was detected positive on frozen section. None of them came positive in the final histopathology. So all the 45 patients were PN0. This is also another important point to note. So the follow-up protocol was clinical follow-up every month in the first year, every 2 months in the second year, every 3 months in the third year, ultrasound follow-up every 3 months in the first year, every 6 months in the second year, and so on. So looking at the outcomes, the mean follow-up of 15 months, one patient had a recurrence, and in whom the neck dissection was later done. About 14 months after the initial procedure, this recurrence happened, and that patient underwent adjuvant radiotherapy later. One patient, we had a suspected recurrence on ultrasound on follow-up, but we did a neck dissection, but the neck dissection was negative. Another interesting thing, in one case, in the final histopathology, even though the MRI thickness was taken only up to 10 millimeter, the thickness, the depth of invasion came as 11 millimeter. Now the question was whether to do a completion neck dissection or to do just give a adjuvant radiotherapy. We discussed a lot, and no completion neck dissection was done because sentinel node was negative, but that patient, based on this depth of invasion, underwent adjuvant radiotherapy. All our patients are alive without any disease. The quality of life outcomes are excellent. Morbidity is less. So what we learned from this 46 patients, we use it for all patients, clinico-radiological T1, T2, thickness up to 10 millimeter on MRI. MRI and ultrasound scan is mandatory. No flap cases. These patients are supposed to undergo no flap. If they are undergoing a flap, we need to open the neck. Then there is no sense in doing a sentinel node biopsy. No neck drains. The duration of admission is usually about 2 days. Mean duration of surgery is around 106 patients, that is less than 2 hours. What we learned, we are redefining the occult nodal metastasis rate in early oral tongue cancers. Only one patient had a node positive in the frozen section, and there was no node positivity in the final pathology. So the completion neck dissection was done only in one case. And also there was one case of recurrence after 15 months. So the effective occult nodal metastasis rate is only 2 out of 46, that is 4%. The classical teaching is up to more than 20%. We know it is on 20 to 30% in T1, T2 or early oral cancer. But mind you, this is based on AJCC 8th edition criteria, where there is a limit to the depth of invasion that is up to 10 millimeter. And another thing which might have led to the lower occult nodal metastasis rate is the strict preoperative nodal screening. That is MRI with contrast. As a radiologist should look at it, and if there is any suspicion that a node is suspicious, that patient will not be included. And again, ultrasound neck was also used. So these two factors might have contributed to the reduction of occult nodal metastasis rate to just 4%. Moving further, whether to raise the threshold of inclusion, where the MRI thickness, whether we can raise it now, since we have shown such good results, whether we can raise it to about 13 or 14 millimeter, that is arbitrary, because there is some, finally the mean depth we have got was only 7 millimeter. Whether to do it like that, or we are thinking of doing a grossing on the table to see the thickness, and then to do the sentinel node biopsy in thickness up to 10 millimeter on grossing, and not to do neck dissection in such patients. To conclude, the accuracy of sentinel node biopsy has been tested in multiple single-center studies and multicentric trials. The pooled data showed an overall sensitivity of 93%, negative predictive values ranging from 88 to 100%. Two randomized controlled trials with high non-inferiority margin have shown non-inferiority of sentinel node biopsy over selective neck dissection. Meta-analysis of RCT support the non-inferiority. At Amrita, we have adopted the procedure for T1 and T2 ensuro-oral cavity tumors according to AJCC 8th edition. Confirmation of the ensuro-nodal status by appropriate imaging, preferably by MRI and ultrasound, is an absolute prerequisite. We have shown promising results. To the paper enthusiast, this is another last paper which I have to talk. Management of clinically node negative early stage oral cancer, a net International Journal of Oral and Maxillofacial Surgery. So what they did is network meta-analysis comparing all these modalities: elective neck dissection, sentinel node biopsy, therapeutic neck dissection, and network meta-analysis was done. And the most effective treatment to find out the most effective treatment and to rank the treatment based on the effectiveness. So this is therapeutic neck dissection, elective neck dissection, and sentinel node biopsy. The smaller the circle, because of the smaller number of patients in the meta-analysis. And they come up with what is called a rank heat plot. And they say direct and network meta-analysis revealed no difference in overall survival, disease-specific survival, disease-free survival, and nodal recurrence rate between elective neck dissection and sentinel node biopsy. And the most effective treatment to obtain the best overall survival for patients with early stage oral cavity squamous cell carcinoma was surgical resection of primary tumor and elective neck dissection, about 72.5% with a moderate quality evidence, followed by sentinel node biopsy, 70% with a very low quality evidence. Thank you very much.
Thank you, KK sir, for such an insightful presentation.
Yeah.
Now we'll move on to our next talk, newer approaches, minimal access approaches, and robotic neck dissection by Dr. Manish Meyer.
Hi, can you see the screen?
Yes, sir.
Hi, thanks to the organizing team for giving this opportunity. I'm going to talk on minimal access endoscopic and robotic neck dissection. So we all know that conventional neck dissection is still the standard of care at this stage. We are still in an early evolving stage with regards to literature for robotic neck dissection. The evolution of robotic neck dissection started with FDA approval of Da Vinci robot in 2009, and there were different indications now, and the indications are expanding in cases where robotic surgery can be used. With also advances in endoscopic techniques and the instruments available, this has been possible to do a minimal access neck dissection. What is the problem with conventional neck dissection? It leads to higher morbidity, as Krishna Kumar Thangappan sir already mentioned, that neck dissection does have its own morbidity, even though it's a routine procedure done for oral cancer patients. It does have a longer hospital stay. It also heals with a poor aesthetics. This is quite common in Asian population, where the keloid formation and hypertrophic scar is more common. And also, it is debatable whether it is oncologically more safe as compared to the minimal invasive neck dissection. So minimal invasive neck dissection, what are the benefits? It gives better function preservation. It is done through the natural orifice, not in this case of neck dissection. Under vision with a lot of magnification gives a better view of the structures which we are dissecting. Similarly, we also have minimal collateral damage because of the magnified view, and these leads to minimal morbidity. It has its own benefit because of less tissue disruption, more functional clearance, and it avoids blind spots because of magnification. It has an improved reach and avoids scar complication, as mentioned before. And because of its good visibility on the camera and the monitor, it has good tool for teaching and training as well. So mainly it is used for skull-based surgery. The role for robotic neck dissection is still evolving. It's well established for TOS and probably parathyroidectomy as well. The presentation for today is basically focuses on robotic neck dissection, which was probably first described in South Korea by Koo and Choi et al. And they have a number of publications talking about its safety and the surgical technique since 2010, 2014. And they did mention that retroauricular is the most common incision used for minimal access neck dissection because of its ease and the feasibility and the access which provides to different levels of the neck. Today, the presentation, I think the topic of the entire panel and the conference is basically looking at the evidence which is available in terms of different topics. I've not included much about the surgical techniques. We'll talk about mainly the evidence present for the safety efficacy of robotic neck dissection. So if you do a quick PubMed search, which I did yesterday, and for endoscopic neck dissection and robotic neck dissection, we have around 600 articles published, and the trend is higher since 2014, when the surgical technique was probably a bit established by the South Korean group. But it is interesting to find the literature is very, very poor at this stage. We have very few randomized control trials, probably one or two, which I could find, maximum three. And quite a few articles were actually review articles or articles which talks about surgical technique. And unfortunately, it is quite heavily concentric data from Korea, and most of the papers which we talk about neck dissection included thyroid cancers rather than oral cancers. Coming to oral cancers, when would we consider minimal invasive neck dissection? So the indication would be patients with tongue, buccal, or lip cancer, which are T1, T2, doesn't require neck access from primary excision, and primary lead, which are node negative rather than a node positive patients. But if you look at the literature, most of them have included N1 nodal disease as well. Contraindicated, again, as we suggested, if the neck access was required, that means in a microvascular surgery or a pedicle flap is needed, where a neck needs to be opened up. And in cases where mandibulectomy is needed as well, again, where neck access would be required. So there are two major approaches for endoscopic versus robotic neck dissection. So what are the benefits of robotic? It provides better ergonomics when the surgeon is sitting in a console and has better access with no tremors. And vision to the surgeon is quite magnificent with 10x zoom. It's quite clear once you sit in the console. When it comes to endoscopic, unfortunately, it gives a two-dimensional view. An assistant has to hold an endoscope, or you can have a stand which can hold an endoscope, but still the view would not be that great, which can have potential increased damage to vital structures. Again, there's no literature suggesting it. It is non-ergonomic because of the setup which we have, and it does have poor replicability, and it's a long learning curve. So obviously, the proponents of endoscopic surgery would suggest that it is safe and it is easy to reproduce because of their experience. But for a new surgeon, it is always going to be more difficult and will have a long learning curve as compared to a robotic neck dissection. We just talked about the various approaches for robotic neck dissection. So that is a transaxillary approach, transaxillary retroauricular approach. Then there is a retroauricular approach with a midfacial lift approach, which is the most common one used, where we can access part of the neck dissection, which is level 4, level 5, 2, 3, 4 posterior part directly, and use robot for the anterior part of 2, 3, 4, and 1A, 1B. Transoral approach which needs CO2 insufflation, and also recently there are publications on robotic infraclavicular approach for minimal invasive neck dissection, which use CO2 inflation. So this is a meta-analysis that was published around 4 years back in 2020, which have included around 11 studies, which summarizes a lot about the outcomes of a robotic neck dissection. What is important to understand that if you look at the country from which this meta-analysis, which includes studies in this meta-analysis, they all probably originated from South Korea, where Cosmos is a big undertaking during a surgery. And there's only one study which is from United States of America. Also, if you look at the sample size, it is very poor. The maximum number of patients in the study is around 140. All of the studies have very small sample size, which varies from as small as 9 patients as well. Most of the common approaches used was retroauricular approach. So if you look at the time for robotic surgery, it was definitely a bit higher, which was around 254 minutes as compared to 189 minutes for conventional neck dissection, but there was no statistically significant difference between the operative time in the two groups. With regards to the hospital stay, there was no difference in the hospital stay for both robotic versus conventional neck dissection. With regards to the nodal yield, which is very important with regards to the oncological safety of neck dissection, we found no difference in a robotic neck dissection, which was around 31 nodes versus conventional neck dissection, which is again a similar number. With regards to the recurrence, to have a good understanding of oncological safety, unfortunately, the follow-up time in each study was average 6 months, which is not very good, but they found there's no statistically significant difference in terms of recurrence between the two groups. If you look at the cosmetic outcome, at 3 months, the data is not very clear because there was no conventional questionnaire used, which was common among the studies. The data was not very clear whether it was a patient mentioned cosmetic outcome or surgeon's assessment of the scar. But there was clear better cosmetic outcome with favors robotic surgery as compared to open surgery. This is quite evident in the scar which was seen in an open neck dissection, which we can see with compared to robotic neck dissection, which is pretty clean, not in the area of radiation as well. So after this meta-analysis, let's look at few randomized controlled trial which are published. This is a comparison between video-assisted and an open lateral neck dissection for a thyroid cancer and a lateral lymph node with lateral lymph node metastasis. They have compared the video-assisted group, which is an endoscopic or a robotic surgery, versus an open group, and they have no difference in the demographic data between the two groups. Let's concentrate on the neck dissection. So the spinal nerve injury is similar between the two groups. Horner syndrome was similar, and there's no difference in the chyle leak as well between the video-assisted group and the open group. But it is important to understand that the post-operative pain was much lower at 24 and 48 hours in the video-assisted group as compared to the open group, and the cosmetic result was much better in the video-assisted group versus the open group. But it is important to understand again that the total operative time was 176 minutes in the video-assisted group and 161 minutes in the open group, which was statistically significant difference. There's no evidence at this stage which talks about postoperative edema, except for one of the papers from Pittsburgh, which does suggest that the postoperative edema is less in the robotic group, which is expected because there's no transverse horizontal incision in the neck, which helps in relieving the lymphedema after the procedure, and also indicate also that the incision is not in the radiation field, so delay in wound healing would not delay starting RT. But this is quite vague. There's no real evidence that it's that favors robotic neck dissection in this scenario. There's a separate meta-analysis for endoscopic assisted neck dissection versus conventional neck dissection in patients with oral cancers. Again, 6 studies were included. Similar results, no difference in lymph node yield, intraoperative blood loss was similar, incidence of complications were similar, locoregional recurrence was similar as well. So, but as mentioned before, there was significantly longer operative time and shorter length of hospital stay in the endoscopic group versus the open group. So this is, as the previous meta-analysis on robotic neck dissection had a very short follow-up of 6 months. There is a paper published by the Pittsburgh group, which actually talks about safety and efficacy of robotic neck dissection with a follow-up of 2 years. Again, a very small sample size of only 45 patients. 15 patients underwent robotic neck dissection and 30 underwent open neck dissection. They were matched group between a particular time frame of 2017 to 2020-21. Again, the follow-up is not long, but long enough to include most of the recurrence within 2 years. They found that the complications were significantly higher actually in the open group, and lymphedema was much less in the robotic group. Spinal nerve injury, which is very surprising, they've reported 10 spinal nerve injury among 30 patients, which is around 33% incidence, which is pretty high. And in the robotic group, the incidence of spinal nerve injuries was only 1. And this was statistically significant. I think the Pittsburgh group is probably more used to doing robotic surgery as compared to open surgery because of the volume which they undertake. Also, the inpatient stay was much low for the robotic neck dissection as compared to the open group, and the duration of procedure was not statistically difference in this study. Again, I would say that because of the high volume center for robotic surgery in Pittsburgh, their duration of overall surgery was not statistically significantly different. This is basically the setup time for the robot, and everything will be pretty quick because all the theater staff and everyone is aware where the robot needs to go, where the patient head needs to be before starting the surgery. If you look at the recurrence and the requirement of adjuvant treatment, there was no statistically significant difference between the two groups. But if you look at the numbers and the percentage, there was a bit higher local regional recurrence of 13.3% versus 6.7% in the robotic arm. Coming to the functional outcomes, so we all know now, based on the previous presentation, that obviously it is cosmetically better, it is oncologically probably safe, but though the literature is very limited with small sample size, mainly retrospective studies, we also have some evidence for functional outcomes and quality of life in patients with conventional or endoscopic robotic neck dissection. Again, very small sample size of 35 patients, 25 conventional group and 10 retroauricular group. There is a definite small hospital stay of 5 days in of 2 days in the retroauricular group as compared to 5 days in the open group. Coming to the range of movement of the cervical spine at 30th post-operative day, this was better in the retroauricular group for neck extension, ipsilateral lateral flexion, contralateral lateral flexion, and contralateral rotation. This difference was statistically significant as compared to the conventional group. There was no significant difference were found regarding the shoulder range of movement, but the trapezius muscle strength was higher in the retroauricular group as compared to the open group, the conventional group. So the main quality of life was impacted in the conventional group with regards to chewing and shoulder domains and physical function dimension at the 30th post-operative day. This was much better in the retroauricular approach as compared to the open approach. This is one more randomized control trial. This is particularly valid for T1, T2 oral squamous cell carcinoma. This basically looks at the immune response and the surgical stress in selective neck dissection when an endoscopic assisted neck dissection was done versus an open neck dissection. Again, small sample size of around 60 patients, 31 randomized to endoscopic surgery and 29 to open procedures. They found that the release of interleukin 6, 10, and CRP was significantly lower in the endoscopic group as compared to the open group, and the cortisol level were also lower in the endoscopic group. This does suggest that the stress of surgery with an endoscopic procedure or a retrograde procedure was less as compared to the open surgery. This also led to a better scar and better post-operative recovery for the patients who underwent endoscopic neck dissection. The major problem with robotic surgery may represent as a major negative point is the cost. There are no obvious cost effectiveness study for a neck dissection comparing robot versus open surgery. But even though if there is literature, it is very difficult to interpret because it is highly variable according to the country. It depends on whether it is a public sector or a private sector. Also, the population we are catering in terms of the treatment. The healthcare system, again, USA is completely privatized. India, it is mixed public and private, but in UK, it is mainly public. And also the hospital setting and the overall operative time and the cost of longer hospital stay with an open surgery. So there's a lot of variable involved to assess the cost effectiveness of robotic neck dissection. Unfortunately, there's no available literature at this stage which can prove that it is cost effective or not. Coming to the summary of robotic neck dissection, when do we should do it? So if the robot is present, obviously that's the first criteria. If it is not available, we should consider an open neck dissection. If the robot is available, surgeon's experience in robotic surgery is very important. Also in terms of complication, in terms of hospital stay. So if the surgeon has a limited experience and patient is frail, cannot tolerate long anesthesia, open neck dissection would be recommended. And that surgeon should probably have more hands-on in other definite indications of robotic surgery like TORS, which is well established, before they can embark into the journey of neck dissection. When surgeon is well experienced in robotic surgery, the major indication would be a young patient when cosmesis is more important. And it should be avoided in older patients when cosmesis is less important because of the cost and the operative time and the wound healing factors. I think the literature is very, very limited when it comes to a robotic neck dissection as compared to an open neck dissection. It's still in an evolving stage. We definitely know that neck dissection is crucial in surgical management of oral cancer. It does have oncologically safe outcome with good perioperative outcomes as well as compared to open neck dissection. But all recommendations at this stage have evidence of level 3 and 4, mainly in terms of retrospective studies with a very small sample size, except for 1 or 2 randomized controlled trial, which is mainly concentrated in thyroid surgeries, which is expected because patients with thyroid surgeries will be younger, have good prognosis with a longer life to live. It compares to robotic neck dissection of a potential for improved cosmesis. This basically was proven in the meta-analysis as well, but a proper randomized trial with a prospective approach is needed. It does also provide some shorter hospital stay. This is a bit controversial because meta-analysis did not prove this, but if you look at individual studies, it does say that patient with robotic neck dissection does have shorter hospital stay because the drain requirement in those cases are less. And this is particularly important in younger patient with HPV disease, which has good prognosis, especially in cases where TORS has been done. We can do a robotic neck dissection, which gives them a good scar without compromising much on the oncological safety. Again, the evidence associated with this is again level 3, level 4, and it's a weak recommendation. Limiting factors for universal adaptation is operative time and the cost involved. Further research is definitely needed to look at the long-term outcomes and whether it is oncologically safe and does it provide the benefit as compared to the open neck dissection. There's one more topic which I've not included the slide on because there's again no literature, is whether sentinel lymph node biopsy can be replaced by robotic surgery or not. I think they're both separate topic probably. Sentinel lymph node biopsy has its own indication. Robotic neck dissection, once it gets established, can be utilized in cases where neck dissection is definitely needed. So I don't think they are interchangeable at this stage. So we will see what future research tells us, and we have to follow that. Thank you.
Thank you, Dr. Manish, for an informative talk on minimal access and robotic assisted neck dissection. So now we'll move on to our next talk, which is on post-treatment follow-up in oral cancer by Dr. Richa Vaish.
Okay, so good evening, everyone. And at the outset of my presentation, I would like to thank the organizing committee, Dr. Asim. So my talk today is about follow-up after neck treatment, importance of imaging and new imaging system. And these are the points that I'm going to address in this talk, and we'll take up each point one by one as it comes. So what are the challenges in assessing the post-treatment neck? The anatomy of the neck is complex and contains many critical structures along with neck nodes. So when a surgical resection and a reconstruction is done with a composite flap and we administer radiation therapy, it makes a post-treatment assessment very difficult. Mucosal recurrences are very easy to identify because we can visualize them, but deep recurrences and neck recurrences can be difficult to detect. So the complex appearance of the post-treatment neck also poses a challenge to the radiological interpretation. So we come to the first question, are all clinical scenarios the same and require the same follow-up? Is imaging in follow-up essential? So let's come to the landmark paper, I think, which underscores the importance of imaging the most, which is a PET CT surveillance versus neck dissection in advanced head and neck cancer. Now, in this 564 patients, 282 in the planned surgery group and 282 in the surveillance group, it was a mixed cohort and a majority of the tumors were N2A, which was 61%. Predominantly oropharyngeal cancer with a median follow-up of 36 months. And when we look at the Kaplan-Meier curve, we see that the curves are overlapping. So PET surveillance is a very good alternative to the planned surgery, and the 2 years overall survival are very similar. And this is evident irrespective of the P16 status of the tumors. The PET-CT guided surveillance resulted in fewer neck dissection compared to the planned neck dissection, and PET-CT guided surveillance compared to the neck dissection also resulted in saving of about 1,492 pounds per person over the duration of the trial. So this trial certainly underscores the importance of imaging. Now let's come to the another case scenario, which is the data from our institutional, from our landmark trial. And this is, does intensification of follow-up influence outcomes in early oral cancer? It's a mixed cohort. Some patients have undergone neck dissection and some patients were on the wait and watch arm. So in this, we had 592 analyzable patients, 295 were allocated to physical examination plus ultrasound arm and 297 to physical examination arm. With the median follow-up of 77.47 months, there was no significant difference in terms of 5-year overall survival between the two arms, with an unadjusted hazard ratio of 0.92 and a p-value of 0.54. Here we can see the curves. So here we see the first curve is the overall cohort, which is a mixed cohort of wait and watch arm and END group. And here we see only in the END group, and we see completely overlapping curve. Also, what we can see in the table here is that time to nodal relapse, median time to nodal relapse when it comes to physical examination plus ultrasound is smaller or shorter. It's only 4.85 months compared to only physical arm, which is 7.62 months. So although we are able to identify the recurrences in a shorter duration, it is not helping in either of the two scenarios when it is a wait and watch or the END. In wait and watch probably because these are biologically aggressive recurrences, and in END because we have already treated the neck, so intensifying the treatment or the follow-up after that either does not identify the too much of a recurrence, or even if it does, it is a biologically aggressive and non-salvageable situation. So it's very, very important. Every case scenario is not the same. So early tumors, probably if treated appropriately and neck addressed, may not need imaging always for the follow-up. But if we have given a definitive chemoradiotherapy to the patient, in those cases, it is important to identify these recurrences in time because we have the option of salvage surgery. Also, if we have heavily treated the patient with surgery followed by chemoradiotherapy, like locally very advanced tumor, again, we have very less to offer. And most of the recurrences in these asymptomatic patients are distant metastasis. So again, it's just a futile effort to identify those recurrences because we really can't offer them any cure. Now, going on to the next question, which is the best imaging modality? Can PETs help in regulating follow-up, and what is the ideal time to do PET? So let's see what literature tells us. So this is the ultrasound in patient with treated head and neck carcinoma. This is a retrospective study published in 2021. And in this, the patients were examined for the 5 years during the follow-up with physical examination, then neck ultrasound, and total there were 198 patients. So majority of the recurrences again we see by the distant metastasis, followed by local recurrences, and lesser number of the regional recurrences. Mixed cohort of patients, and this is what authors concluded, that neck ultrasound in the follow-up period is reported to be effective for the detection of recurrence of patients who receive primary treatment for carcinoma of the head and neck. But please note, this is for the regional recurrences in primary tumor stage 1. So if we have just done the surgery or given a single modality treatment, probably we can think about doing the ultrasound, but as we saw before, it doesn't add much to the survival benefit. Now coming on to the next publication, which is a comparison between the diffusion-weighted MRI and 18F-DG PET-CT parameters in head and neck squamous cell carcinoma following definitive chemoradiotherapy. Now, this study had 56 patients, and these were stage 3, stage 4, so locally advanced head and neck carcinoma patients, and these patients underwent evaluation at 12 weeks post-treatment. They compared the diffusion-weighted MRI parameters like apparent diffusion coefficient max and minimum, and in FDG PET, they identified SUV max and XUV max ratio to the liver, and they measured it in the primary tumor as well as the lymph node. So what they found was there was no correlation between the diffusion-weighted MRI and the PET-CT parameters on 12-week post-treatment imaging, or their interval changes from pre-treatment to 12-week post-treatment imaging. So the authors concluded that the parameter on diffusion-weighted MRI may be independent biomarker. However, only selected parameters demonstrated prognostic significance. So probably even the diffusion-weighted MRI has a limited applicability when it comes to this scenario. Now, this is a meta-analysis which is published from our institute, and it looked at the diagnostic performance of post-treatment FDG PET or FDG PET-CT in head and neck carcinoma patients. And in this, 51 studies were included and more than 2,000 patients. So it looked at the diagnostic performance of the PET in the response assessment. And here we can see that when it comes to the neck, it has an excellent negative predictive value to the tune of 95%, very good sensitivity, upwards of 70, good specificity. So it's a good tool to look at the neck in the surveillance period or after the definitive treatment. What is the ideal time? Again, it looked at the two cutoffs, less than 12 weeks and more than and equal to 12 weeks. And we can see that when it comes to the node, and even for the primary for that matter, although not significant and significant in nodes, the sensitivity and specificity both are much higher if the PET scan is performed after the completion of or at the completion of 12 weeks. Now, with this background, we do understand now that PET scan is probably the ideal modality when it comes to the post-treatment assessment. And this is the American College of Radiology Neck Imaging Reporting and Data System, NIRADS, and it's a white paper that was published in 2018. It's a lexicon and basically to standardize the reporting. So in August 2016, ACR formed the Neck Imaging Reporting and Data System Committee. So initially this NIRADS was proposed for CT basically, but then it extended onto PET-CT. And the aim was to standardize the nomenclature to facilitate uniform reporting, simplify communication, and allow radiologists to make unequivocal recommendations. So these were the primary goals when the NIRADS template was created for head and neck cancer surveillance, to reduce the ambiguity of narrative interpretation by the use of numerical categories to convey the level of suspicion of recurrence, to link these category of suspicion to the consensus management recommendation, to improve direct patient communication by the radiologist and including concrete or actionable next steps, and to build a multi-institutional large database to more accurately assess the probability of the disease and facilitate research. So these are the NIRADS category. Incomplete is if we don't have the baseline imaging and we have just one imaging, so it's difficult to then comment on the probability of the recurrence, so that is 0. NIRADS 1 is when the probability of recurrence is very low, and in this it is only the expected post-treatment changes. So this NIRADS has both the PET and the CE-CT component. So there is no mass-like distortion of the soft tissue. We can see just diffuse mucosal enhancement or FDG avidity. There is no other abnormal FDG uptake and just a linear mucosal enhancement. So that is no evidence of recurrence, category 1. Then we have a low suspicion of recurrence, which is 2A, when we have a focal mucosal enhancement, but it is not mass-like, or focal mild to moderate mucosal FDG avidity. If we have a deep, ill-defined soft tissue, but not discrete avidity, no differential enhancement, again, moderate FDG avidity, again, it's a low suspicion and it is category 2B. High suspicion are if we have a new enlarging primary mass or lymph node, or we have discrete nodules or mass with differential enhancement, as we can see here at the site of primary and at the site in the neck. So these are high suspicion. It has intense focal FDG avidity. And definitive recurrence when we have a pathological diagnosis. So these are the parameters which are considered when we are reporting a NIRADS mass, whether it's a non-mass like soft tissue, mucosal abnormality, and this is in context to the lymph node, and we can categorize them. So based on the category, if it is the category 1 low, it's a normal thing, and then we just can go ahead with a routine surveillance. When it is low for suspicion, like category 2A, we can just go ahead with the direct inspection to see if there is any mucosal disease. If it is 2B, then probably we can repeat a PET scan 3 months later and see whether the disease is progressing or resolving. When the suspicion is high, one has to go ahead with biopsy. And if it is a biopsy proven recurrence, we have to go ahead with the management plan. Now, this is the NIRAD system. The question is NIRAD a robust system for the follow-up of all patients? Now, this is the initial performance of NIRADs to predict residual or recurrent head and neck squamous cell carcinoma, published in 2017. A total of 318 scans, 618 targets, both primary or more than 300 primary and nodal targets. Now, in 618 targets, when they looked at the NIRADs category and the recurrence rate, it correlated perfectly. So we can see that when it comes to the lymph node, that NIRADs 1 has the recurrence rate of only 4%, NIRADs 2 has 15%, and NIRADs 3 has 70%. And same is reflected also into the ROC curve, and where we can see that the area under the ROC curve is 0.75 or 76. So it's a good tool, and the prediction is pretty accurate. When the authors compared the CT component and a PET CT, so they found that it correlated well. When it came to NIRADs 3, the prediction was better in the CT component compared to the PET CT component. But anyways, the best way probably to go ahead is the combination of the two, that is PET CT, and taking into consideration both the parameters. Now, this is the data from our institute in which we looked at the diagnostic performance of response assessment FDG PET CT in head and neck squamous cell carcinoma treated with definitive chemoradiotherapy and using NIRADs, published in 2023. So this was 190 patients that were after the treatment response assessment FDG PET was performed, and then retrospectively the NIRADs category were assigned from category 1 to 3, and this was done for primary site, neck, and both the sites combined. Now again, we can see that from our data as well, it has an excellent accuracy of upwards of 85%, very good negative predictive value of upwards of 95%, good specificity and sensitivity. Again, the area under the ROC curve is very good, where we can see for the neck, and when we combine primary and the neck together, it is upwards of 0.80 in both the cases. So it's a very good tool when it comes to the neck assessment after the treatment. Now, this is another publication again from our institute, and this compared the CT component and the PET component in the PET CT performed to assess the disease status on the first post-treatment follow-up. Again, we can see a good concordance when it comes to the category, but there is a discrepancy when it comes to NIRADs 3. And accuracy of CT in predicting the disease is again very good when it comes to all the 3 categories, that is 1, 2, and 3. So CT component is also very important. Now, how can we use the various imaging system to regularize our follow-up protocols, and which imaging system is the best? Now, we know that there are various ways of reporting when a PET scan is done, and there are various optical interpretative criteria like Porcedu, which takes into consideration the avidity when compared to the background activity of the normal tissue or the background liver activity. Then we have Hopkins criteria that compare it with the internal jugular vein and liver. We have Duval criteria in which they try to quantify when they compare it with the liver, and NIRADs, what we just talked about. So does it make a difference that which criteria are we using for reporting? Now, these are the results, and we see that the accuracy is by and large same, whichever way of reporting we use. So across all the categories, we see that the accuracy is upwards of 85%. But number of indeterminate scores for NIRADs, Porcedu, Duval, and Hopkins, when it came to the neck nodes, were 55, 70, 18, and 3. So lesser number of indeterminate nodes when it comes to Duval and Hopkins. So authors concluded that all the 4 interpretive criteria have similar diagnostic performance characteristics, but Porcedu and Duval score offer the best trade-off of minimizing the indeterminate outcomes whilst maintaining the high negative predictive value. And NIRADs today is the most commonly used system in the head and neck. Now, how will the practice change in the next 10 years pertaining to the methods we use for the follow-up and frequency of neck imaging on the follow-up? So do we have the answer? So we know that we have to do it at 12 weeks, that is 1 scan. So what do we do beyond? Now, this is a study of 255 patients that looked at that is there any added advantage of extending the evaluation beyond 6 months. So in this, they identified recurrences in 23% of the cases, and 36% of which were clinically occult. Means patient did not have any clinical manifestation of the disease, but these were identified on imaging. The median overall time to radiologically detect clinically occult recurrence was 11.4 months from the treatment completion. And this was a protocol that they used to identify these recurrences. So first PET-CT was done at the 3 months after the completion of the treatment. Then after that, if everything was okay, then a repeat CT run was done 6 months later, and another CT at 1 year after that. And if any point in time there was a suspicion of the CT, on the CT, it was complemented with a PET. So again, we can see that the median time to recurrence is 16.5 in NIRADS category 2. And it is 9.7 in NIRADS category 3. So probably if we extend it to 1 year or 6 months after the first scan, there may be some advantage. But is there any advantage beyond? Certainly no advantage beyond 2 years. Here we can see the rate of recurrences. When we go by the clinical and the imaging, there is a difference in the identification, but we see that at 24 months, there is a plateauing of the recurrences. So initial 2 months, they may have some benefit, but there is beyond 2 years, it has a low yield and high cost. So it may not be very, very beneficial in extending the follow-up. But we should be very, very careful. Now, this is another publication in 2019, and it clearly showed that clinical and radiological follow-up identified more recurrences and second primary cancers than the symptom-driven monitoring. But the curability of cancer recurrence was similar, regardless of the detection modality. And therefore, prospective trials are needed to define the most effective follow-up strategy in head and neck cancer. So we have the key is to identify the correct patient in whom the intensification of the treatment is going to benefit instead of applying everything to all patients. And that is where it's going to make an impact. So we have to be very, very careful. So we go back to from where we started, that the case scenario is extremely important. Where is the future? Future probably is a precision medicine, and we are going to use the biomarkers and genome sequencing to identify the people who are at risk of recurrence, and probably those patients will be intensifying the treatment. But it's the future. We have to see how it evolves. And the last part of the talk is standardization of quality of life assessment post neck dissection. So there is a lot of heterogeneity when it comes to the quality of life post neck treatment. It's very important to assess the quality of life and as it impacts the patient significantly. There are numerous publications with different patient-related outcome measures and performance done at different time points. Common ones are EORTC 30, 35, SF 36, neck dissection impairment index, EQ 5D, 3L for health utility, neck dissection quality of life questionnaire. So a lot of heterogeneity and no consistency that which one is the ideal one and when to do it. So this is again from the PET neck trial, and it's the analysis of the various questionnaires that they have used, EORTC 30, 35, and EQ 5D, 3L. And time points were 2 weeks after the chemoradiotherapy, 6 months, 12 months, and 24 months. And these were the outcomes captured, comparison between the two groups. And authors concluded that quality of life scores were slightly better in the surveillance arm. And compared with planned neck dissection, PET-CT surveillance produced an increased net benefit of 0.16 QALYs over the trial period and 0.21 QALYs over the model lifetime horizon. So it's very, very important for us to understand that now in future, whenever a trial is being conducted, the quality of life should be one of the objectives so that we are able to compare it, and we should have a more specific neck dissection specific questionnaire that should be used, and the cost utility and cost effectiveness also should be incorporated in those trials. So this is just to conclude. If we look at the NCCN latest version of guidelines published in May 2024, so these guidelines recommend that FDG PET-CT should be performed within 3 to 6 months of definitive radiation or systemic therapy or radiotherapy for assessment of treatment response and to identify any residual tumor. Anything, if it is done before 12 weeks, there is a higher chance of having a false positive rate, and it should be avoided unless there are obvious signs of recurrence or progression. The optimal timing of the PET scan, therefore, is between 3 to 6 months, and a negative PET scan at this point in time predicts a good overall survival. In patients receiving definitive RT treatment for the mucosal squamous cell carcinoma, if there is N2, N3 disease and it is it's an unequivocal response on the PET scan, then probably we should go ahead with the neck dissection. There are modalities at our disposal, but PET scan is most sensitive in detecting these recurrences. And at 12 months, PET scan is able to identify about 10% of recurrences, and at 24 months at 5%. But if these recurrences are detected in the asymptomatic patient, these are mostly distant metastasis where we have very less to offer. So we should be very, very judicious till what time point should we implement this kind of a follow-up. Now, if the FDG PET-CT at 3 months post-treatment is negative and there is no data to support a routine use of PET-CT in such a scenario, a clinical examination is good. It can be supplemented with the ultrasound. And if there is anything worrisome on the ultrasound, then we can think about complementing it with the additional cross-sectional imaging. So the take-home message is that case selection is very, very important. Every case does not warrant a similar kind of intensification of the follow-up. PET-CT is more sensitive in detecting the nodal recurrence compared to other conventional modalities of imaging. Limited use of sequential imaging if the PET is negative at 3 months, that projects a good overall survival. The ideal time to do PET-CT is 12 weeks post-treatment. There are multiple optical interpretive criteria to report PET-CT. Any can be used because they project the similar outcomes, although most rampantly used is NIRADS. Early detection with follow-up imaging at 12 months and 24 months may identify distant metastasis, but it does not impact the outcome. So it's questionable for how long to extend. The future lies with the biomarkers and the genetic sequences, genome sequences to predict the recurrences. And there is a need of clinical trial to decide the modality and frequency of routine imaging in asymptomatic patient. And these trials should also encompass longitudinal follow-up for assessing the health utility and quality of life using neck dissection specific questionnaires. Thank you.
Thank you, ma'am. We appreciate your informative talk on crucial aspects of follow-up in a head and neck cancer treatment patient. Now we'll move on to our next session, which is a roundtable meeting discussion on the neck dissection consensus.
Okay. So good evening, everyone. So just before we started, we had the presentation on what are the points that we're going to have at the end. And we'll discuss on those once again. So we'll go with each point one by one. And we would like comments from all people in the committee to come to a conclusion of what is the best diagnostic modality for a neck. So whenever we are working up an oral cancer, a T1, an early oral cancer and an advanced oral cancer. So what is the best diagnostic modality? What is the minimum investigation that we must have before we proceed for managing a neck? So this can be taken up by anyone. Yes, Shreya, please go ahead.
Hello, am I audible?
Yes, you are audible.
Yes, sir. So, when we ask this question, what is the best diagnostic modality for neck in baseline imaging of head neck cancers, or particularly oral cancers, what we are following at TMH Mumbai and TMH Varanasi is that we do a CT scan for the buccal mucosa cancers and we do an MRI for the tongue cancers. And we extend the coverage of the scan to include the neck. So in case of tongue cancers and in buccal mucosa cancers, MRI and CT respectively are good enough for picking up nodal metastasis. That is as sensitive and also very specific. If at any point of time we have a doubt about a particular node which is indeterminate on the contralateral side, we go ahead with doing an ultrasound. And we have seen with our experience at both the hospitals that even when a CT is showing a node to be indeterminate, we are not able to decide. And ultrasound has helped us because we get a more zoomed image of the node wherein we can talk about the specific morphological features which help differentiate a benign from malignant. So I think the best protocol to follow would be CT for imaging of nodes in case of buccal cancers, cancers of the hard and soft palate. And for oral cancers and oropharyngeal cancers, we do an MRI and determine the nodal metastasis on the MRI by extending the coverage to include all the cervical level nodes.
Okay, share just one more point before we conclude this point. CT and MRI, we definitely agree for the buccal mucosa and the tongue that you discussed and the oropharynx. Now you said the USG being more specific when we, as a problem-solving tool, when we are not able to conclude whether we are going to use any other investigation.
Yes,
Does
sir.
anybody have any difference of opinion? And Dr. Sir Devendra Chakar sir, you also had a study where you had analyzed the different imaging modalities. And Dr. Richa and Manish also have to say something on this point. Please go ahead.
Yeah, so Asim, they were here. Shreya put it very well. Whatever modality, you hear me, Asim?
Yeah, I can hear you, sir.
Whatever modality is being used for primary, so it's basically boils down to why are you evaluating the neck? Because in majority of the cases, you will be operating the neck. Yes, in some cases you want to evaluate the contralateral neck. So MRI have equal sensitivity and specificity as far as neck dissection, neck management goes or neck detection goes. So you can do it. You can use the same modality that you're using to evaluate the primary. Very well put by Shreya. The only question here is for the N0 neck for a small primary. As Krishna Kumar elegantly put it, you should do one of the modalities to make sure that the N0 if you're going to do a sentinel lymph node biopsy. So that's very critical when you're doing a sentinel lymph node biopsy to make sure that the neck is N0. And for your question on sentinel node biopsy in N0, I don't know whether you want to take it now, but yes, that's the future. And every institute, those who have the backup of nuclear physicist and pathology, should do at least 15, 20, I think it's about 25 cases to evaluate the sensitivity, specificity of your, at your institution.
Sir, I'll just ask another question. To put up more clearly that CT and MRI, when we are very clear whether we are going to address the neck or not address the neck, we are sure. However, when we have a CT and an MRI, which is telling us inconclusive, will a sonography in that case add on to us or no? So that as a clinician, what is your opinion on that?
So Shreya said that well, and most of us do follow what she said, that if majority of the time the CT will say that's indeterminate and you don't know what to do. And most of them, they report the opposite side. You're more important on the opposite side, right? Because most of the times you'll be operating the ipsilateral neck and they'll be reporting some indeterminate node on the opposite side. So it's a problem-solving tool. Ultrasound with guided FNAC, if necessary, is a good modality that she said, and we follow that.
Thank you, sir. And now another point I have, if a patient is walking in with only a sonography of the neck, so is it a good enough investigation to proceed with our management, or should we always do a CT and an MRI as required? Manish, you can take up that question.
So I think it's I don't think an ultrasound should be okay, because the sensitivity as per the various meta-analysis have shown that the sensitivity of detecting a positive neck node is equal with ultrasound, CT, MRI. But I think as a routine protocol everywhere right now, we always do a CT or MRI depending on the site of primary. So I think it's a routine protocol to consider a CT or MRI depending where the primary is. But if you look at the literature, probably it should be okay. I would also just make a very good comment that whatever diagnostic modality we use, we still will miss a significant number of positive neck node. And obviously, even with sentinel lymph node biopsy, we will have some negative results. So that is important to consider while managing any neck.
Thank you, Manish.
Asim, could I just make one
please.
point?
Yeah, definitely. Please go ahead.
So in context to the ultrasound, I think Manish very rightly pointed out that whether it is CT, MRI or the ultrasound, the sensitivity is in the same range. So it is not that ultrasound by itself is acting as a problem-solving tool. The advantage of ultrasound is if you have the indeterminate node on the contralateral side, you are probably going to go ahead with the FNAC. Because otherwise they will give you similar kind of a picture. So it's not more sensitive in picking up the disease. So probably it's a guidance to the FNAC, which is the added value with the ultrasound.
So thank you so much. So we conclude the first point that whenever we have a primary.
Can I make a point here? Can I make KK here? Hello.
Yeah, please go ahead, sir.
So one point about ultrasound, you have to understand that the literature talks about different sensitivities and specificities about ultrasound. We have to understand it is a purely operator and expertise dependent. So at a particular institution, you will have to go back and do an audit of your own, sensitivity and specificity of the ultrasound. So that is very important, because the expertise, expert radiologist has to comment on ultrasound, and we have to believe what they say if we are not doing an ultrasound. That is one point.
Okay, so I'll conclude the first point that whenever we are working up a patient and the minimum imaging that we require is a CT scan or an MRI scan to have a baseline imaging. Now for the contralateral, since USG is an operator dependent, so that is not very specific, and it may be used as a problem solving depending upon the expertise that is available with us. Manish, I think we can take on further points on this point later on in the further meetings whenever we are preparing the consensus, because there will be a lot of points to discuss again. So we'll come to the second point now on multi-omic markers used to predict occult metastasis. So Arjun, can you please elaborate upon this and how we can use this as a marker in future? Arjun, are you there? Arjun, does anybody who has been working upon the multi-omics as a marker for meta-analysis or would like to comment upon this point?
So, Asim, can I come in here?
Yeah, please.
So, circulating DNAs, and there are few other markers which have been used for this. Thing is, they all are in evolutionary phase. We still don't have any definitive evidence. Like, of course, some people come in and say, okay, that this can be used. But then they are still in evolutionary phase. There's nothing definitive which we can recommend as of now to predict occult nodal metastasis.
Okay. So as of now, we do not have any level 1 or even a level 2 or 3 evidence to suggest that we'll be using multi-omic as markers. A lot of research on these particles is going on. So as and when we have the evidence, we'll definitely discuss upon this point.
This is Monita here, and I agree with Akshat. This is in the research domain and not yet in routine practice. There's not much evidence to recommend as a routine practice.
Thank you, ma'am. And the third point now, can sentinel node biopsy evaluate an N0 neck? So we definitely have a lot of wonderful presentation from Krishna Kumar sir, and he had elaborated upon how we can utilize. So Krishna Kumar sir, would like to elaborate anything upon this?
No, nothing more. We have enough proof that it is a good investigation with good diagnostic efficacy.
Okay, thank you, sir.
So shouldn't we be discussing about morbidity with sentinel node biopsy, whether it is of any advantage or not?
Sajid sir, please go ahead.
Sure, Akshat made some point. Please, Akshat.
Akshat, please complete that.
Sorry for coming in, sir. I didn't know you were speaking. I was asking that, like we are talking about sentinel node biopsy, we definitely know it has got, place in staging the neck. But then when we talk about morbidity, say versus neck dissection, so like there are randomized evidence which have shown non-inferiority of the SNB, which KK sir very nicely mentioned. But about functional morbidity, what are the thoughts of people about that? Whether SNB is equivalent to neck dissection or it is worse or it is better than that. I understand we are doing less, but then still, is it really any different from neck dissection? Like the scatter diagram in one of the RCTs, they show that after 1 year, the mobility, shoulder mobility between the two is actually the same.
Yes. So I have a question from Krishna Kumar sir for the same point now. Like whenever we are using SNB for addressing or not addressing the neck intraoperatively or perioperatively, that we are very sure we have the evidence to do that. In future, is it possible that we are having some radio tracer uptakes, just like we do a CT scan or an MRI, if we are able to do a sentinel node biopsy in a similar fashion, and then plan our management whether we are going to address the neck or not in subsequent, like in a week's time? Is there something going on in this regards?
No, I didn't quite. The question is not very clear. Can you repeat that, please? What is the question?
Just right now, whenever we do a sentinel node biopsy, we inject the dye into the peritumoral area, and then we do the gamma probing and scan it.
Yes.
In future, is there any study going on new radio tracer uptakes, which may be doing or conducting the scans in form of a CT scan or an MRI scan right now, which can help us stage an N0 neck without addressing the neck, without even infiltration?
No, I don't think there is any non-invasive things, but the studies are finding out better radio tracers, like where we can the logistics can be improved. Like we can do it immediately, we can do it after like 1 day, and so on, to improve that. But without injecting a radio tracers, it may be difficult, because all the visualization techniques are not conceptually good. For example, in the terms of if you are talking about this, what is it? ICG and blue dye, everything is based on our vision. Such techniques are not conceptually correct, because if, for example, if the sentinel node is in a contralateral side or in ipsilateral level 4 side, it may not be visualized without fully exposing the neck. So such techniques are conceptually not correct, and so may not be useful.
So right now, the sentinel node biopsy, we cannot be utilizing for all cases for staging. But yes, we can use imaging to confirm whether it's an N0 neck, and then subsequently subject the patient to a sentinel node biopsy and decide whether we are going to address the neck or not address the neck. Correct.
We have to prove N0 prior to the decision. We have to make a decision point.
Arvind sir, you want to say something?
Can I?
Sure, sir. Please go ahead.
Okay, the same point. We all know by literature and the work shown by Amrita people that a sentinel node has got value. But last few patients, I had been trying to standardize and then understand the sentinel node. I'm finding it difficult. So can we have a vote or something? How many of us really do sentinel node? I have not been able to standardize that in the last 10 patients. So it is not that easy. So if we are trying to say or put up a guideline for India, I think it is going to be a difficult task to suggest that sentinel node should be done or can be done. Because again, the learning curve and then problems.
Sajid, totally you are correct.
Your opinion.
Sajid, that is totally correct. It is not a thing to be done routinely. The routine procedure is every patient should get wide local excision and a proper neck dissection. That is the standard of care. If you have the facilities, expertise, the nuclear medicine, the pathology, everything is in proper, you can do it. Otherwise, it will be it will be damaging.
Sir, could I make a point?
My suggestion is that we shouldn't make a recommendation for doing it as of now, probably.
So we are not making a recommendation of doing it right now. We are just trying to see whether we can use sentinel node biopsy for staging in all cases.
Yes.
If that is feasible, because till that is not feasible, we will not be able to apply for all centers.
So,
yes, ma'am, please go ahead.
Can I just make a point there? So in last 3 years, we have done upwards of 110 patients. So initially, we also had glitches, but once you cross that 10 and 15 marks, so if you read all the guidelines, they say minimum that you need to do is 10, because that is a learning curve. But what we believe, we went a little ahead, and it is not only the surgeon that has to be accurate, it has to be accurate at every level. So the nuclear physician who is injecting the dye and identifying the node for us when we are taking it out and when the pathological processing is being done. So when we say 10 to 15 as a learning curve, the entire team has to do it. So that is minimum what is needed. And now having crossed 110 and standardizing it against elective neck dissection, I think it is not that difficult, but definitely it has a small learning curve.
Okay,
Yes.
so we are now talking about running it in a form of a trial and then moving ahead. I think Arvind Krishnamurthy has to make a point, sir. Please.
Yeah, Azim, it's just a basic thing. Like for example, you put up certain questions, and my understanding is we try to give a crisp answer to that question. For example,
Yes.
this is, can sentinel node evaluate an N0 neck? So there has to be no ambiguity. We'll say yes, it can, and then subsequently you grade the sort of evidence, and then subsequently you can add a few lines on the recommendation.
Okay, sir.
That it has to be done in a high volume center, dedicated center, and all the other things. So
Yes,
even
sir.
for the previous question, like a multi-omic markers, can it be used? We say no, that is a statement. And then subsequently we will say what are the things in the pipeline. So
Yes, sir.
my understanding is that may be the way to go about, because since you have actually asked a particular question, we need to be very, very clear in the consensus statements that we are going to come out with it. And then subsequently you can add a paragraph or more with the evidence, and then quote the evidence at the end of the consensus document, I guess.
Yes, sir. Thank you, sir. Thank you, sir.
Yeah.
So we'll move to the next question now. So we are very clear about the types of neck dissection. So we are going to utilize the classification of using a selective neck dissection with the levels 1 to 3 or 1 to 4 that we are addressing, or modify selective neck dissection level 1 to 5. So that is the nomenclature that we are going to be utilizing this for the neck dissection. Now the question comes, when to do a neck dissection in an early oral cancer? Now, this is,
I think
will be between two things, whether we are using a sentinel node biopsy and when we are not using a sentinel node biopsy. Yes, Krishna Kumar, sir.
No, the answer is very, very clear. If you are not using a sentinel node dissection, it should be done in all cases. We don't have robust evidence to avoid neck dissection in tumors thick depth of invasion less than 3 millimeters. So that is my clear answer. If you are not doing a sentinel node biopsy, it has to be done in all cases.
Okay. Everybody agrees to this
only
point?
Yes, only thing is we should have we can avoid in pre-malignant situations, like if the biopsy
Pre-malignancy
comes as moderate
different.
dysplasia or even severe dysplasia. These are two situations, because those clinically also would look something like a malignant, but sometimes we get the biopsy the report as dysplasia or severe dysplasia. Those are the situations, but all proved squamous cell carcinomas, I think we should consider as of now.
So,
Agree.
yes, sir.
I totally agree with both these here. But the one thing I think that Vijay is also asking is from Manipur, that what about diagnosed case of verrucous carcinoma, and if it is definitely approachable from oral cavity, that we can easily go ahead with wide excision intraorally. So what will be our recommendation?
So, can I take that question? Verrucous carcinoma, the problem is it cannot be conclusively proven preoperatively. That is a problem. So verrucous carcinoma may have to be done multiple biopsies. Even after multiple biopsies, we may not be able to prove an invasive component preoperative. Many a time, after the final biopsy, it may come, there may be an invasive component. And then if we are willing to do a stage neck dissection, that is fine.
Exactly. So I think KK said, for the recommendation, if we can go with that if there is verrucous carcinoma, which can be intraorally done, so upfront neck dissection is also a possibility, because majority there is squamous carcinoma after final, but otherwise doing a staged neck dissection is also an option.
Yeah, if the patient is willing for a staged neck dissection, that is fine.
That is fine. So, but if the patient willing that one way but patients should be given both the option. Is it okay?
Yes.
I
Yes,
need Richa.
Yeah, Saurabh, I feel what KK sir said is more appropriate. So if we don't have the diagnosis of verrucous carcinoma, that is when we should counsel the patient that there is a probability that you may get the invasive cancer later and we may have to do a staged neck dissection. But if right in the beginning we have the diagnosis of verrucous carcinoma and we know that it has sometimes, up to 5 to 10% focus of very well differentiated carcinoma, so probably better to do the neck dissection in the same sitting. I think this is what KK sir meant.
Somebody from BBC
No,
wants to make some point. Please go ahead.
Asim, small point is here. As I totally support KK, and what I feel personally, it depends on the stage of the disease, because if the disease is more, if we see a T2 plus borderline T3 or some more than that, it's very difficult preoperatively only one diagnosis, because we really do not know in such a larger stage in what point it breaches the basement membrane. So I think it's safer to do a neck dissections.
Thank you, sir. Saurabh sir, you are saying something?
No, okay. Means I agree with means verrucous carcinoma. Then I think expert panel recommend that neck dissection, upfront neck dissection should be the choice, but patient should be given both the option if he is not willing. Is it if the patient is not willing? Is it okay? I don't know, so what will be the conclusion?
So verrucous carcinoma, early stage T1, T2, where we have a negative histology in the preoperative, in those cases, we may avoid doing a neck dissection upfront. However, if it is an advanced T3 or a T4, we'll definitely go ahead with the neck dissection upfront.
Okay. Let's go ahead.
So now the third point is whether to do a selective neck dissection or a modified or a selective neck dissection or address all the 5 levels of nodes.
For N0 also?
For N0 as well as N+. So this will come for both the situations, whether it's an N0 or an N+ neck.
I think Asim, if I can take that, the recommendation is quite clear on that. If it is clinico-radiologically N0 and during surgery itself we find no suspicious lymph nodes at level 2, then level 1 to 3 or level 1 to 4 is an adequate surgery for an N0 neck. Probably for tongue cases, we might extend and definitely recommend doing a level 1 to 4, given that there might be a slightly higher incidence of skip mets in tongue. But I think for the broader view, level 1 to 3 or level 1 to 4 should be recommended.
For a clinically
So that brings a yes. So that brings up a question.
Yeah.
Okay, so that brings up a question, Harsh. Whether will you do frozen section of all the suspicious node intraoperatively? Because if you do frozen, there is a high likely that you may end up in diagnosing more of positive nodes, and then will you convert them into modified neck dissection if it is positive in frozen?
That's a very tricky question. Now we need to remember that we are writing these guidelines for the country at large, and all centers may not have a frozen section available. So based upon your radiological findings, based upon your own clinical judgment as well, in case a surgeon finds a suspicious large node at level 2, then he may go ahead and do a level 5. He is not wrong in doing a level 5 in that kind of a situation. Like I would suggest we write the guideline or we write the recommendation, assuming that most of the centers do not have a frozen section available.
So Harsh, could I just make a point there? So if we go to look at the guidelines, whether it's a ESCO consensus guidelines, they recommend doing a level 1, 2, and 3 clearance when it is a node negative neck. They don't suggest doing a frozen section. Frozen section, we have the liberty and luxury of using it, but it is not the standard of care even world over. So when it comes to the clinico-radiologically node negative neck, it is all about level 1 to 3 and level 4. But of course, if there is a large metastatic node, which to us is appearing a metastatic, it makes complete sense. But if it is clinico-radiologically negative, that probability is slightly low. And also the study published from Tata again showed the same thing. So if we have done elective neck dissection, clearing out level 1 to 4, and even if it was positive or small or frozen, doing a completion neck dissection did not identify a level 5 metastasis. And even in mixed cohort, it is less than 4%. So if probably for elective neck dissection, 1 to 3 / 4 should be okay, I guess, based on the evidence and recommendations.
Add on a question on this now. Clinically, N0 neck, we will definitely go ahead with a selective neck dissection, and we are correct in doing a selective neck dissection level 1 to 3 or 1 to 4. For a clinically N plus neck, where we find a node at level 1B, what do we do for that?
I think a single node at level 1B without gross ECS, we can still go ahead and recommend doing a level 1 to 4 or a level 1 to 5. I think both level 5 can be avoided in that particular scenario where you have a single node without ECS. But many a times while doing a level 1B, since we take the entire fibrofatty soft tissue component together, it will be very difficult for a surgeon to identify exactly how many nodes are present. Or even if there is, minor ECS, then whether, to be able to judge that for a surgeon will be quite difficult.
That is why I put up this thing, a clinically single node positive at level 1B or a CN1 at level 1B. How do we go ahead in making a recommendation for single node positive at level 1B? Manish, you want to say something?
Yeah, I think there is a meta-analysis which talks about node positive neck as well, where they have compared a 1 to 4 versus 1 to 5, and they've not found any significant difference in survival outcomes. Again, kind of reinforcing the statement which Richa made in NHS as well. There's no way we can do frozen section for every case. Also, the radiotherapy which is given, if it is a node positive and we have done 1 to 4, the radiotherapy will cover level 5 anyways. And if it is clinically negative in level 5, it is probably a micromets which can be dealt with the radiotherapy. And the incidence would be so low to prove a statistically significant difference, you need a very large sample size. So 1 to 4 might be adequate in clinical node positive case, but I think if you look at the guidelines, we should always do 1 to 5.
For a guideline, we must say level 1 to 5 when we have a clinically positive neck.
Exactly. What Pani said, that if you see the literature, there are meta-analyses showing that equal, but we have to consider two facts here. That oral cancer is basically a disease of our country. Means you cannot find what type of aggressive neck we are seeing, or what type of aggressive diseases we are routinely saying advanced diseases, and so there should not be any compromise in neck, because the ultimate outcome, quality of life, definitely it is a matter of concern. But you can understand one thing, that 75% of our patients, when they come to us, is the data, they are stage 3 or 4. So I think in our scenario, we should emphasize that still MND should be the standard of care for neck in N plus neck.
Okay.
But I don't know.
Can I make a point out here?
Yes, Akshat, please
Others
go ahead.
will have
Can I
different
say
opinion.
something here?
Yes, ma'am.
I think Manish made the point that we would like to do neck dissection only from 1 to 3 and let radiotherapy take care of level 5. But that's not how it happens, because routinely if the neck is negative, we do not treat level 5.
Ma'am,
we were talking about node positive neck.
Node
Yeah,
positive
we
neck,
don't
single
treat
node
level
positive.
5. We don't treat level 5. We don't
Okay,
do it
ma'am.
in India.
Okay, so single node
Because I
positive
know
will
the
be-
international guidelines suggest doing level 5, but we have again and again in the Roy Istro courses, as well as in Istro also, told people that we don't do level 5 in the node negative neck, especially in oral cavity cancers. We don't do level 5. If all the other neck is negative.
Ma'am, we are talking if it's a single node positive at level 1B, then also you'll not be
No,
covering
we
the
will
level
not
5.
do level 5. We will not do
Okay.
level 5.
Okay. So a level 1 to 4 neck
Ma'am, in
dissection in
which
that
case,
scenario.
ma'am, in which case then we include only in level 5
When you have
positive?
to be involved, when you have extra nodal involvement at level 1B, 2 with a large proportion of nodes that are positive and with extranodal extension, only then will we in histopathology include level 5. But in most cases, we do not include level 5 unless there is obvious nodal involvement at level 5.
So this is my question is, so I know that the level 5 metastasis incidence is really low. Low. I have no doubt about it. But my point is, in our scenario, when we are seeing a lot of cases when there is microscopic ECS and all, which we are not been able to understand during surgery, how safe it is to leave behind level 5 or even level 4 if we are talking about SND 1 to 3.
Someone speaking, I can't hear you.
Hello?
Hello, Saurabh, I lost you in between. Did you say something?
Sir, ma'am, my question is, in our country, when we are seeing a lot of patients have microscopic extracapsular spread, which we have been able to identify only after the histopathology reports are come, and the incidence is quite high. A lot of our patients are receiving CTRT. So, in our scenario, how safe it is just to do level 1 to 3 or 1 to 4 in N plus neck clinically?
So see, so that's exactly what I'm trying to tell you. When we address the neck with radiotherapy, we go by doing it depending on the risk of involvement. Now, we definitely know that the risk of level 5 involvement without a level 2B involvement or without extensive lymph node involvement without ENE, we don't get level 5 involvement. And we don't do it in oral cavity unless we find 2B involved or there is extensive lymphadenopathy with ENE. So if you think that the radiation oncologist treats the level 5 to at least 50 gray, we don't do it.
So, ma'am, to finally conclude this point, so whenever we have a clinically node positive neck at level 1B, we can safely do a level 1 to 4. And level 5 can be taken care if there is a level 2 or a level 3 positive in the neck dissection, provided we do,
Yes.
and we are doing this because we do not have a frozen section cover.
Yes.
Asim, can I just make a point there? The Liang meta-analysis that we keep quoting for clearing out level 1 to 4 compared to 1 to 5 now, one, it has very small numbers, some 250 or something. It's not a very large meta-analysis. That is point number 1. And the second point is,
450.
That's what.
Yeah.
So, and the second point is that it talked about low volume N1 disease. That is the kind of the term, if I remember it correctly, was used. Now, low volume N1 diseases, a node has to be less than 3 centimeter and it has to have no ENE in our current definition of HACC. Yes. Now, if a node is clinically manifest, most probably it's something, if we are so easily palpating it, it's usually more than 3 centimeter and it may be associated with ENE. So it looks like, very small neck nodes, which you identify either on histopath or if you're sending the frozen and you are identifying really N1 disease. So maybe for those case scenario, it may look apt, but if it is clinically manifest, it becomes a bit questionable. And third point is, if you read that meta-analysis very, very carefully, it talks about supplementing it with the radiotherapy. And madam is clearly saying that we will not be covering in our Indian scenario level 5. So then to say it so categorically that if it is a clinically manifest 1B, will clear out level 1 to 4 only is a bit skeptical, I feel.
So, any
So
point,
what I would say.
Asim would like to. Yes, ma'am.
No, let Dr. D'Cruz say.
Sir, would you like to say something?
Go ahead, Sarbani. I'll listen to you. I'm at some other conference. I just joined in. I'll make my comments after you make yours.
So what I'm trying to tell you is, all of you are saying that when the neck dissection in the N0 neck is concerned, you will do a level 1, 2, 3, right?
Yes,
now,
ma'am.
based on the histopathology report of that N10, what you call 1, 2, 3 dissection, if it is negative, no problems or indications at the primary, we may cover the neck. But if it is an N1 and it is an N1 or an N2A, that means you have no one node positive extranodal extension, I will not cover the level 5. Typically, when we do level 5, it is when the level 2B is positive or you have overwhelmingly positive lymph nodes at level 2, 1B with extranodal extension is what I'm trying to say.
Asim, can I make a point, please?
Yeah, please go ahead.
Asim, I really feel what we are discussing for nothing. Number one, nowadays we do neck dissection in a single incision. Number one. Number two, in attempt of taking level 3, level 2, the two clearance of level 3. And to be honest, there is no such very clear-cut distinction between level 3 and 4. So, if at all we are of those soft, loose areolar tissue in the same incision, it hardly making any sense. So, it's comprehensive neck dissection is the better plan. Whenever you feel that there are some solutions, take it out. I don't feel this is what we practice, taking out.
Okay, sir. So what we're talking about is a clinically single node positive that has been detected. It's less than 3 centimeter, a small node that has been detected. So we are right in doing a level 1 to 4. However, we are still skeptical to put that as a guideline to say that we'll be only doing level 1 to 4 in such cases.
Asim?
Yes, sir.
I totally agree with what Sarbani is saying. Level 5 is not to be operated routinely in an oral cancer. And there are many reasons that we say that. There's an old paper by Davidson looking at 1,100 patients with patterns of failure. Level 5 failed in less than 1% of patients. Look at Gauri's paper, 583 patients. The incidence of level 5 was 3 point some percentage, and it was only when 2A was positive or it was a retromolar disease. Tongue really doesn't go to level 5. And if we had a high failure rate at level 5, the radiation oncologist would be covering it in the field of radiotherapy. The negative of doing level 5 is that you'll always get impairment of the accessory nerve. The nerve is most vulnerable at the posterior triangle. So I would go with what everybody said, more or less. 1 through 4, though even 4 is not mandatory, but I kind of agree with Ashok. You just have to fish out. I won't go all the way and bang the clavicle, is what we should do for all patients who are clinically node negative or have small volume N1. If you have an N2 node, you have a level 2B large nodes, you will definitely go and do a comprehensive neck dissection. But by and large, no one does 5 anymore.
Yes.
And you can put it as a guideline. And
Yes,
you
sir.
don't need to do a randomized trial to answer that question.
Thank you, sir. So we finalize this point that level 1 to 3 is fine for a clean single node positive, and level 1 to 4 or 1 to 5 is only required when level 2 or level 2B is positive. Now the next question, like when can we avoid a neck?
And Asim, you can add a rider in buccal retromolar cancers from the Gauri Pantvaidya paper.
Okay, sir.
That should be another alert point. So if you have 2 large nodes, it's retromolar, your threshold of doing 5 should be lower than if it was a tongue.
Sir, just one question. In case of multiple node positive, we should restrict ourselves to 1 to 4?
No,
what would be the
multiple positive is not small volume disease. You'll do a full comprehensive neck dissection, and Sarbani Ghosh will radiate the opposite neck as well.
So, sir, the guidelines should be, then we are only talking about single positive node in 1B. So what about if there is a single positive node in level 3?
Even single positive at 2, you can do it. Farlito has a systematic review. You can read it.
Okay. So
I think, Saurabh, we are talking about the PN1 status.
Ma'am, we'll come to the PN1 right now. No, I'm talking about CN1. Sir,
we are
about
talking
CN1.
about we are talking about CN1 because in a lot of cases, ma'am, we get PN1 even PN2 because we may get multiple node positive in an SND, and definitely we are not going back to do level 5 in that cases.
No,
if
so
it was
correct.
clean.
No, so now
we
see,
are
if we-
talking about what about if there is a single node positive clinically N1, or if there is clinically positive multiple neck node or single level 2 or 3 or 4 node. That is my question, that whether we are going to write this, that only indication of in all cases we can do level 1 to 4 except multiple
So I'll just put those things, I'll just reframe that and rephrase this thing.
Yeah.
Clinically N0, we are going to do 1, 2, 3. Clinically N plus single node positive or low volume disease, we are going to do level 1 to 4, and we are not going to address level 5. When we have N2 disease with high level of nodes in level 2 or 3 clinically positive, we are going to do level 1 to 5.
So Asim, it should read like this. SND is a valid options in patient CN1 and a selected CN2 neck disease where there is non-fixed nodes, absence of palpable metastasis at level 4 and 5, or large volume greater than 3 centimeter multiple nodes at multiple levels. That's how it should read.
Okay, sir.
Good.
Sarbani, would you agree?
We should also.
I think we have several other points left, so we'll move on to this point. We can also come up with the evidence in the subsequent meetings.
Yes, sir.
Well, we should also say how many nodes has to be there, because is it the same which has been already recommended, because we don't have any recommendations in India.
So we'll come back to this point
selective
once
neck
again. We
dissection.
are discussing it for a long time, and this rather than discussing again and again on the same points, that how many nodes we can get onto these points, we'll discuss this point separately once again. So now coming to the next question, when can we avoid a neck dissection? Clinically, in a clinically T1, T2 tumor, when can we avoid a neck dissection? As of now, the evidence says that selective neck dissection is a standard of care. So when we do not have any frozen, when we are not doing any sentinel node biopsies, then we are going to address the neck in all cases of T1, T2 cancers, as per the guidelines. Does everybody agree to this?
No, Asim, it should read that a neck dissection can be avoided when a sentinel node biopsy dissection, a sentinel node biopsy has been planned, or the surgeon or the treating clinician is reasonably certain that the depth of invasion is less than 3 millimeters. In brackets, you can write, particularly if the tumor has been excised prior and histological proof, and close the bracket. You cannot make dogmatic statements. It has to be open-ended. But it should.
Thank you, sir.
Sir, this 3 millimeter thing and giving it, I think I have a reservation, because do we have that robust data to say that 3 millimeter below we do not have to do neck dissection? And sir, I really think that when we are particularly saying that is in our country, a lot of people, they are doing for a small tongue and they just scrap it, and so will it provide a lot of people to do whatever doing without neck dissection?
No, Saurabh, you'll never have robust data to answer that. You'll never have level 1, and I'll give you my reason, but you've got enough data. You've got data from the Huang's meta-analysis saying that 4 millimeters cutoff resulted was not harmful. And they looked at the rate of positivity of nodes, and they've collaborated lot of studies, and you can, it's in cancer. Sarbani will give you the reference.
Sir, I
Sophie,
know that
yeah. Then
4% to 16% to jump with 4 millimeter and more than 4 millimeter.
That is our study that jumped. Now I'll tell it to you in how it works. We showed that for every neck dissection that you do, if you do 8 neck dissections, you will save 1 life. So we powered it on a 12.5% overall survival benefit.
Yes, sir.
Now, if you have a less than 3% incidence of metastasis to the neck, you will have to have 200 patients undergo a surgery to have a benefit of 12.5. So no one will ever do it, right? So you can do it. That's not wrong. You will have some patients who will recover. It's not like it will be 0%, but 1 to 2 millimeters. If it is excised outside, I won't do the neck dissection, and I'm fairly convinced of the data and fairly convinced of the safety for my patient as well. But I keep them under intensive follow-up in case they're in that lucky 1, 2, 3%, unlucky 1, 2, 3%.
So, sir, can we grade it a little more? Because we are not talking about the tertiary cancer center scenario. We are talking about all other scenarios where the depth of invasion probably may not be even properly reported on the histopath, and compliance could be an issue. So if it is an interval neck dissection and we have the histopath at hand and it is 2 to 3 millimeter, probably we may keep the patient under follow-up with intense surveillance. But if it is in general a scenario where we are going ahead with the tongue surgery and we don't have the depth of invasion available, it's probably better to do the neck dissection in all, especially when it is compliance is difficult to ensure.
Guidelines are not written this way. Guidelines are written when you are reasonably certain of 1 to 2 millimeters. You cannot be dogmatic in any guideline. And you don't have to bother about the country. They'll all do for very early. Firstly, they won't see early lesions in the countryside. Then they'll all do neck dissection, ligate the facial artery. The patient will come with a recurrence. And then what do you do when the neck is already screwed up? So you should write when the surgeon is reasonably certain that it is 1 to 2 millimeters. In brackets, you can write particularly when histopathological proof confirms the DOI less than 3 millimeters. That's it. You can't be dogmatic and decide who's going to operate the neck in the countryside. In guidelines, you read any guidelines, they're not written like this. Saurav, all of y'all are trying to give definitive answers. It's not possible. If they were definitive answers, Asim won't be calling this meeting.
Okay. So thank you, sir. Manish, you want to make some say something?
Hello, yeah, I was just adding one more point is obviously the depth of invasion is important. Should we consider other histological factor like PNI, LV, E, if they are present? Like there is evidence that if there are more than 2 adverse histological factors, the incidence of nodal metastasis increases. So that is one point I want to make. And I agree with Dikru, I think we have followed up around 77 patients with no adverse features with depth of invasion less than 3 mm. And only 1 has recurred and we could operate on her and radiotherapy was given and she's disease-free as well.
Okay. So
hello, sir.
Yeah, please go ahead.
Sir, I had a doubt in a situation wherein there is predominantly hyperplastic lesion, but there is a small focus of microscopic focus of invasion, which actually happened with one of our patients. The pre-op biopsy was varicose hyperplasia, but the post-op histopathology detected a very small focus of invasion. So in such case, should we counsel the patient for a neck dissection, or should we give option to the patient?
If it's an incidentally detected small focus of invasion where we do not even know the depth of the invasion of the tumor, in those cases, definitely we can avoid doing a neck dissection.
Okay, sir. So this can also be one of the conclusion that we can take from this thing, that if it's a hyperplastic lesion with a small focus of microscopic invasion, we can still omit the neck dissection.
Yes.
Okay. Okay.
So now coming to Sarvani ma'am, ma'am, what will be the role of elective neck irradiation in a N0 neck?
To see if somebody is, I would tell you how it is. Elective node radiation, elective nodal dissection is the preferred modality of treatment. However, if somebody has come with surgery already done, and if there is a high risk, and if the surgeon is not willing to go back in for the neck, that is when you can consider doing elective nodal irradiation for indication sometimes at the primary.
Sarbani,
Yes, sir.
you have to make that comment with caution. Peter Brennan, June Corey's study where they tried this approach, they had to stop the trial. But they were thicker tumors. Just read that trial. 25 patients,
Yes,
they
sir.
stopped
That is
it.
the one, that Australian trial which they had to stop.
Correct. Correct.
Yes, sir. But today, the only indication for doing neck dissection, elective neck irradiation is when the neck is clinically N0, the surgeon is not going in, and there seem to be indications for radiation of the primary. That is the only reason to go and do elective. Otherwise, the standard of care is elective neck dissection.
Ma'am,
So
can I phrase it this way? Like if
Let's hear, sir, once Asim.
Yes, ma'am.
No, let him phrase it, then I will come on.
Okay.
So for a elective, for a node negative neck where a primary has been addressed, and because of any medical conditions, or we cannot go in for doing a neck dissection, or there is any fitness issues, in those cases, we may consider giving an elective neck irradiation.
And it is CN0.
And it is N0. Dikru sir?
What you are saying is correct, but it has to be worded very carefully. And you must write that when you're sure or reasonably certain, it has to be an open-ended. You cannot be dogmatic. You should write that adverse factors, the neck should be addressed. However, if radiotherapy is being considered for the primary factors, firstly, if radiotherapy is being considered for primary factors, I'm not sure how I'd answer this question, because if radiotherapy is for primary factors, it's quite a big tumor. I would go ahead and you should put an option of an interval neck dissection and then give the patient radiotherapy. I don't know, Sarbani, would you agree with that?
So, as you're saying, this statement has to be made very carefully. I personally think that is the case. But as you're saying it, I think I kind of agree with what you're saying. But then supposing the surgeon is not going back in, so that's why I'm making a very conditional statement. Otherwise, actually, the standard of care is elective neck dissection.
Yeah, you should write it that way, Sarbani. And even the Dutch study with Virgir and all, they showed that if you have CN1 as opposed to PN1, then it's always better to do the neck and then give radiotherapy. Yes. They didn't reach statistical significance, but it did show a trend towards. So please word this guideline carefully.
Okay, sir.
Sir, could I just make a comment there? I mean, everything what has been discussed is perfectly fine. But if we look at our N0 paper also, when we look at the wait and watch group, in that we did give radiation to the neck for the primary that were high risk. So neck was covered in those cases also. So it's a kind of elective neck radiation in those cases, and they did not do well when it was compared with the elective neck dissection. So my interpretation is that both the options are not very comparable. However, if there are contraindications to address the neck because of any medical condition, only in those cases, probably it's worthwhile considering. Otherwise, it should be elective neck dissection always.
Sir, I think we should put it like consensus guideline does not recommend elective neck dissection in routine cases. Only in those conditions where medical condition, even surgeon's preference cannot be written that surgeon doesn't want to go. if a medical condition doesn't allow surgery, in those situations, elective neck irradiation may be considered.
Yeah,
Thank you.
but don't recommend the Sarmani. We won't recommend primary radiotherapy for N0.
Sir, I told sir we should write that guideline doesn't recommend elective radiation in any routine cases. Only in cases where surgery is not feasible due to medical condition, then only elective resection may be considered as an alternative.
I agree to what all of you are saying, and actually even I'm saying the same thing, that please don't do elective neck irradiation, because the standard of care is elective neck dissection. So, Asim, I would suggest that you frame the sentence, because you're any which way is going to pass the guidelines around, right? And I think this particular statement should be considered carefully before giving it out to the mass.
Okay, ma'am. Now coming to the another point once again. So can elective neck irradiation be done for a N plus neck? So we'll all say agree with the no for this, and we'll frame the words carefully for this one as well.
I think so.
So we'll come to the next question. When to address a contralateral neck dissection in a T1, T2 primary, and then subsequently in a T3, T4 primary. So for any clinically node positive neck on the contralateral side, will be consider doing a bilateral neck dissection or a contralateral and addressing the contralateral neck, or any large primary that is reaching midline, or any tumor that is crossing midline, we will be doing a contralateral neck.
Yeah, but
high volume nodes.
Yeah,
so Asim, I would word this that contralateral neck dissection should be considered in T1, T2 cancers, if there are multiple nodes involved on the ipsilateral, even if the lesion is far from the midline. But don't write far from the midline. It sounds a little weird, but for particularly large T2, if there are multiple ipsilateral nodes, if it crosses the midline or reaches, or it's T3, T4, we always do the opposite neck.
Okay, sir. So for T1, T2, multiple node positive neck in the ipsilateral side, we may consider doing a contralateral neck. Any disease that is reaching midline will be definitely, we'll be doing a contralateral neck.
And T3, T4.
And T3, T4 disease.
Even if it is unilateral.
This is for the tongue tumors.
Correct.
And for the buccal mucosa?
Large nodes, large nodal burden on the ipsilateral side.
Should we include anything about the skin or any other points for this?
No data in my understanding, but Sarmani, today would you radiate the opposite neck with multiple nodes on one side?
So that would be at level 1B, and at level 2 if there are multiple lymph nodes with extranodal extension. And especially for a lateralized lesion, I would not do it otherwise.
Yeah, so absolutely. So those are the indications I would do the opposite neck. Perfect.
So thank you, sir. So now coming to the next point, can a pathologically N1 neck be safely observed without adjuvant RT? So this point was raised by Sarvani ma'am. I would like to answer this. So when can we observe a neck which is a PN1?
See, PN1 routinely, if there are no indications for adjuvant RT at the primary, and it is a less than 3 centimeter node, then we can observe a PN1 and not consider giving adjuvant radiotherapy.
Just one question to Sarvani ma'am. Is it related to the level of the node? Like in upper neck, it's fine, but if the node is in lower, suppose 4 or something like that? then what will you do?
So, Ashok, I know what you're trying to say, that if it's a low neck PN1, you like to observe, but then here we are discussing oral cavity, I assume. So if you're
Right.
discussing oral cavity and if it's a PN1, we're talking about the level 1B or the 2. And if there are no indications for radiotherapy at the primary, you can leave the neck. You may not radiate the neck.
Sarbani, I have a little different opinion from you.
Yes, sir.
There, in my book, I radiate the neck in 4-5 indications. One for an N1. One is when you have a T2 tumor, and I think the meta-analysis is Yang meta-analysis. Was it Yang?
Yes, sir. Yang was the thing that talks about giving an advantage even for the PT1, PN1.
No, T2. It's a NCDB database. I'll tell you
Yes,
the
sir.
reference. I'm out on the road, so I'm just a little.
No, sir, you're correct, sir. You're correct about Yang, but I'll just tell you. Sir, you complete your statement, then I'll tell you, sir.
My second indication for radiating N1 is if the patient has more than a 1 centimeter lesion, particularly in tongue, and that's from the Krish study, Krish Soren or whatever his name was, when they showed that if it was more than 1 centimeter, there was a detrimental effect in outcomes. The third time I would do is exactly what Ashok said. If they skip metastasis at known levels, aggressive disease, I would do it. I would do it for tongue, where the primary lesion and my resection has to cross into the base of tongue or across the midline. I would 100% do radiotherapy. I'll never observe an N1. And the last is if it has more than 2 adverse factors. Even if it's an N1, 100% I'll give radiotherapy. There are 5, and this is well described in literature.
Sir, I agree with all your points. So that's exactly what I was saying, sir, that if you don't have indications.
Sarbani, you made my day. First time someone has agreed with all my points. I'm signing off here. I have to hop into a cab. But go ahead, Sarbani.
So if I'm saying if there are no indications that warrant adjuvant radiotherapy at the primary. So what Ashok said was a low-lying neck node. Yes, because that kind of is a harbinger of disease, which is going to do badly. But if you don't have any indications for treatment at the primary, that means it is a PT1, TN1, you really have to discuss with the patient and consider giving adjuvant therapy. The later thing, what you call the German study, actually now talks about this extensively. You've talked about the Yang study. The Yang study actually tells you that PT1, PN1 may reduce the number of events. The same thing is told even by the study in which you have this German study, which is the latest one, which tells you that definitely with PT1, PN1, there is an advantage of giving adjuvant radiotherapy because it decreases the number of loco-regional events, but at the same time does nothing for the overall survival. Whereas if you have a PT2, PN1, then you give adjuvant therapy definitely because it also impacts the overall survival. So what I'm trying to say is if you have no indication that, then if you have more than 2 adverse features, there is no reason not to give the radiotherapy because these are patients who warrant adjuvant radiotherapy. But what I'm saying is if you just have a PT1 or PN1 which does not warrant adjuvant radiotherapy, you may really have to discuss with the patient and decide whether you want to give adjuvant radiotherapy. These may be patients where you may observe them because of the morbidity of the treatment involved.
Ma'am, I have a question from you before we proceed. So when we talk about PN1, does the method of how the reporting of the node has been done important? Because what happens is if there is a possibility that there are certain other nodes that may be missed on a histopathology reporting. That is less likely,
Asim, I
but
don't
there are
understand
possibilities.
this. You may want to ask
because we are
Monica
talking about step serial sectioning for increasing the diagnostic rate specifically when we are trying to do with a sentinel node biopsy. So when we are trying to do a step serial sectioning and there is a small focus on the node that has been detected, as compared to a single node which is studied along the hilum as well as along the perinodal area with the
Yeah,
tumor.
so this is what
In those
Dr.
cases.
Dikru said, if your node is less than 1 centimeter in size, you may think of less than 1 centimeter, you may think of observing it is more than 1 centimeter. Actually, some people say 1, some people say 3, because then the incidence of ENE, if you were to do a more detailed sectioning, would be much higher. But if you do routine neck dissection and you have a node, that is because, as the nodal size increases with the metastasis, the incidence of perinodal extension also increases. Hence, it is usually said that a node that's more than 1 centimeter, and some say more than 3 centimeter PN1, less than 3 centimeter PN1, you may want to observe if there are no indications for adjuvant radiotherapy at the primary.
Okay, so ma'am, can I rephrase it like that? When there is no indication of radiating because of the primary, and the node which is PN1 is less than 1 centimeter and a small focus of disease in that node, then we may observe safely
and in the
observe
upper
without an
neck,
adjuvant
and in
therapy.
the upper neck,
And in the
and in the
part of
upper
the
neck.
Yes,
Yeah.
ma'am. Does anybody would like to make any other statement on this, or shall we move ahead?
So this 1 centimeter cutoff of the lymph node is an arbitrary cutoff. Is it based on
It's not
something?
an
Or
arbitrary
it's a-
cutoff, We have some radiotherapy studies actually which have these values, but they're older studies. They're not very new, and I cannot tell you the references offhand, but we have some studies.
Okay.
Yeah, you're quite correct, Munita, but we have some older studies on this. Yes.
So now coming to the pathologist, like, does step serial sectioning increase the diagnostic rate? And I'll come again with the second question. Can step serial sectioning be followed in a routine neck dissection for all cases?
So the question that step serial sectioning increases the diagnostic rate, that is the answer would be yes, but it is whether it is required and clinically beneficial, that is not routinely recommended, right? So it is at the discretion of the pathologist. If they see something doubtful, they will do step serial sectioning on their own, right? So, but there is no protocol which tells you that step serial sections have to be done on all nodes. So
So ma'am, I'll just
it's
add
not
on to
a
this.
routine. It is just at the discretion of the pathologist.
So routine
In a
use of
routine
step serial sectioning is not indicated,
No,
not recommended.
no,
But
there is
you said that you will, at your discretion, decide that you are going to do step serial section because you are having some doubt.
yeah,
like,
that is on the initial review of the slide. If you find that the ENE is doubtful, or I have a doubt about the metastatic focus, then I would do deep serials and confirm it, or verify the findings. But it is not a recommendation that in all the lymph nodes as standard guidelines that you are required to do n number of serial sections. So that is not practical, not for routine cases.
Okay, ma'am. The next thing is how to pathologically report a neck dissection. Once again with the pathologist.
So there are various guidelines which are available. The ICCR guidelines are there for neck reporting. There are some core data items that you have to report. Presence of lymph node metastasis, the total number of lymph nodes. Then at each level, you have to report the number of nodes with ENE. Then the size of the metastatic deposit as well as the size of the involved node. That is also recommended. And the size and presence of ENE and the extent of ENE. And now it is recommended that you also mention the number of lymph nodes which have ENE. So not just the presence or absence of ENE, but also the number of nodes which have ENE. So there are various guidelines. ICCR data sets are there. Then we have CAP guidelines. All of them, there are various guidelines which we can reference, which are standard guidelines. So these standard guidelines should be used to incorporate all core data items in the pathology report. So we can
Thank
list
you.
out all these. Yeah.
Yes, and we'll come with the step serial sectioning and this use once again in the sentinel node biopsy as well. So we'll come to the next question on the role of sentinel node biopsies. So what are the standard dyes isotopes for performing a sentinel node biopsy? Krishna Kumar sir, Dr. Richa.
Sorry, Asim, could you repeat the question?
Yeah, ma'am. What are the standard dyes or isotopes used for performing a sentinel node biopsy?
So at TMH, we are using a technetium 99 labeled human serum albumin. That is a nanocolloid. We can also use sulfur colloid. That is a gold standard. And adjuncts can be methylene blue and indocyanine green. But as already discussed by KK sir before, those are not the ideal tracers because you have to open the neck place. So a nanocolloid probably would be ideal.
Okay. So we are clear with this question. Now coming, should SNB be done for all cases of N0 neck as a recommendation?
No, it cannot be recommended universally. Cannot be recommended universally, only if expertise, availability, all those things should be there.
Okay.
And also we should emphasize that even if our institute is doing it, they should complete that learning curve before they start sparing the neck. So at least 10 to 15 should be done before sparing the neck, minimum.
There should be some standardization on other fronts also, not just surgery, but nuclear medicine perspective as well as pathology perspective. That standardization needs to exist.
Yeah.
So we cannot recommend a routine use of sentinel node biopsy in all cases. We have to complete the learning curve and follow the standardization for the pathology and the surgeon and the nuclear medicine team together before we start conducting a sentinel node biopsy in any of the centers.
Yes.
Now the next question is the sentinel node biopsy the standard of care in Indian context?
No.
Can we elaborate something upon this?
I mean, again, if you tell in the Indian context, it cannot be taken as a standard of care.
Okay.
Because
but we'll have to phrase it some for the guidelines.
We have done a national survey on this. We even published this in OOO, that majority of surgeons feel that they are unprepared. This is amongst head, neck, surgical oncologists both, that they are unprepared to do SNB for oral cancer as of now.
Okay. And is SNB suitable to be practiced in all centers?
No.
Needs infrastructure.
Why should we comment about any country? We should comment only about our country, right?
Okay. And who is the ideal or suitable case for a sentinel node biopsy? We need a definition here right now.
That I've told, like it should be T1, T2, AJCC 8 with MRI head and neck and USG neck. MRI to prove the thickness and MRI and ultrasound neck to prove it is N0. Clinico-radiologically N0.
And sir,
yeah.
And sir, in our country, should not we use the term also accessible in term of adequate mouth opening? When we have extensive cases of a lot of cases of oral submucous fibrosis.
Oh yeah, obviously. That is, I think, it is understood, I think, Saurabh.
Okay.
Yeah.
So only in cases
flap cases, any cases requiring flap or any cases where there is no mouth opening, all those things cannot be done. That's obvious.
So we'll post for the indications of a sentinel node biopsies. In cases where we're going to do a transoral excision of the primary, no reconstruction is considered for them. Clinico-radiologically N0 as per AJCC edition and T1, T2 primary.
Correct. Proven
now this question is, what modifications and future developments are needed in SNB to make it useful in all patients in our country?
Modifications and future developments. That's all research, right?
Yeah, so like maybe from some new radio tracer that can be worked upon, or some ideal radio tracer that we can define that can be used for all cases if we are planning sentinel node biopsy for all patients. If you can define something like
you can have any recommendation on this. This is forward looking.
No, I don't think we need to make up. We can take it off, I guess.
The reason being that we'll have to put it because this is an area of research and it is going on extensively. And there are certain trials, multiomics and other things are also being tried. So we will have to at least address this issue. We may not be completely defining it, but we'll have to put in a paragraph for this also.
Yeah, that's fine. I mean, attempts to develop better radio tracers. And yeah.
Pathology infrastructure is also needed. You need a 10-fold increase in your pathology infrastructure if you want to incorporate it in routine service.
So generally, we should talk about improving the infrastructure like nuclear medicine, pathology, and surgical expertise to be improved. Steps to improve all this.
So we already had this question. So what regulation changes are needed to establish a sentinel node biopsy across all the hospitals? We have the answer that we'll have to develop the infrastructure for the pathology and the nuclear medicine and the standardization technique across these departments before we start performing a sentinel node biopsy in any of the hospitals.
Okay.
So now coming to the pathology once again, how is a neck specimen in post-sentinel node biopsy evaluated and how is it evaluated differently? So Monita madam.
No, can you repeat the question? What do you mean post-sentinel node neck dissection?
Post-sentinel node biopsy, when we process the...
How is the
specimen...
sentinel node biopsy treated? Is that what your question is?
Yes, ma'am. How is the sentinel node biopsy reported? Will you be doing step serial sectioning for all the cases, all the nodes?
So, it depends on what the institutional policy is. There is no standardized way of doing sentinel node biopsy evaluation. The best examples are from the breast and the melanoma studies, where this is much more standardized. In the randomized trials, one of the techniques used is very detailed, and that is in fact the best technique, where you have 150 micron. The whole node is used in step serial at 150 microns, and you supplement it with IHC. So that is an ideal way. And what it actually addresses is these ITCs. You are basically picking up more ITCs, right? So you have to see what is practical for your institute, and you have to. So each institute has to come up with the protocol that their pathology team is able to handle, and then also come up with the negative predictive values and the sensitivities by doing a pilot or a validation study. So there are different ways in which it can be handled. You can have just incorporate in a staged procedure where you have frozen section first and then supplemented with IHCs later. So at 2 millimeters. So that can be the minimum that can be done, where you have a 2 millimeter slicing of the lymph node, and that is supplemented on paraffin with immunohistochemistry. But on the other hand, you can do multi-step serial sections throughout the lymph node, you at 150 microns. And even there can be an intermediate, something which is done in RCC, that you can take out some levels where you stain with both HE and IHC. So what is the methodology that is to be used? That has to be standardized. So in each institute, so there is no single methodology which is standard of care right now. So for instance, we have one protocol for a trial that we are going to start. That is already underway in TMH. So that is the policy that we are using. But otherwise, there is no standard procedure for oral transfer in terms of pathology evaluation. That this is the method which has to be used. So that is the challenge.
Using step serial sectioning?
So step serial sections of some level are required because they increase the diagnostic yield. But whether we are chasing the ITCs or whether we are chasing the micrometastasis, which are clinically beneficial, so that we need to decide. So 2 millimeters slicing of a lymph node, that is useful. That can be supplemented with IHC. That is kind of the Japanese way of the Sagesawa trial. Whereas if you want to do multiple micron sectionings, 150 micron at the intervals of 150 microns, then that requires that is not possible outside of a trial setting. You require a lot of infrastructure for that. So we have to decide what are we aiming for, whether it is for routine practice and what is our goal, whether we are chasing ITCs.
So we recommend IHC for routine practice.
So right now there is no recommendation internationally. What is the recommended guidelines for pathology evaluation of sentinel lymph nodes? So there are no uniform guidelines. So each institute and each trial has devised their own protocol. That is the challenge.
So what do we make a recommendation for? Like suppose we want to have any center that is starting or practicing sentinel node biopsy for histopathology reporting. So what should we discuss about using? Yes.
Yes. It's clear. I don't think there is any confusion here. We have to, if we are doing a sentinel node biopsy, there should be serial step sectioning, and we should have ideally a frozen section, and then HND and cytokeratin immunohistochemistry. That is what we follow.
Okay, so, and what is the pattern for the trial that we are running in TMH? Is that what is being followed there?
So there we are following 150 micron levels with complemented with IHC. Is that correct, Richa?
Yes, ma'am. That is what we are doing for trial. So for the frozen section, we are taking 2 mm blocks. So that is the initial part intraoperatively, and then subsequently serial step sectioning at 150 micron and IHC.
So when
that would be around 130 slides per case, approximately.
So
that was the
talking
calculation.
about a guideline, ma'am, when we're talking about a guideline for practicing in our country, so when right now in the centers that are practicing, they are advising step serial sectioning with frozen section backup and a cytokeratin IHCs. Now, when we are giving a guideline for any center that is starting, they have to do this minimum at this level.
Yes.
Aseem, I think serial step sectioning and IHC is a must. Now, it's all about whether it is 150 micron or 250 micron. The most stringent protocol is 150 micron, and little liberal ones have a little wider serial step sectioning, like Japanese protocol. But serial step sectioning and IHCs, it has to be there.
Yeah. So we right now we need to have a step serial sectioning and a IHC along with it for a good diagnostic yield for all cases in which we are doing a sentinel node biopsy.
Correct.
We'll come to the next part of the minimal access neck dissections. So Manish, why and when do consider a minimal access neck dissection approach?
I think it is in this case, I think we should say it is not recommended at this stage, considering the amount, the evidence which is present. However, we can consider in young patients and thyroid cancers and
talking about the oral cancer right now, please. So
okay, so I don't think you should recommend a routine robotic neck dissection at in the present scenario, considering the cost effectiveness and the robotic service which is present at how many centers and the experience of the surgeon. So it should not be in the hand of a new surgeon who is just starting his robotic journey. So I think at this stage we should not recommend it.
We can say may consider for by a trained surgeon for patients requiring cosmesis.
Yeah, that becomes a bit vague, I feel, but we can always say a young patient with good prognosis. Yeah, young patient, good prognosis, concerned with cosmosis.
Aseem, I just feel that we should specify like how many procedures to be performed in the learning curve before, harping upon. So like we are using it for SMB in the similar way, so that it becomes safe if anyone
we
is
have to define a learning curve for a robotic and a laparoscopic assisted neck dissection before we say that we can routinely advise it to be performed by anybody. And we do not have any guidelines to say, and only in very low volume diseases where we concerned about cosmesis, in those cases we may try. However, there is no level 1 evidence right now.
The same guideline cannot say we may try. So, I don't know, means I have not read, but now what is the evidence for means how much evidence we have robust. So when we are talking about guideline, that it is a safe option, the clearance is equivalent to conventional, we have to ekbar check. And then if it is there, then we can only say that in our country, considering the fact that robot is not available widely, and especially robotic training from head and neck surgeon is not that much, because robot is means in a lot of places, but the training for head and neck surgeon is not that robust, unlike urological or gynecological. So we can say that only in a very few trained center it may be practiced if the data is enough to support that it is equally safe and effective as conventional.
Okay.
And I think Ratan has mentioned an important point in the chat box, that this should not be called minimal access. It's actually maximally access.
See, what happens is when we are
It can be remote access. Yeah.
And then, but how can you? But how can you say remote access if you are considering also the laparoscopic?
So even laparoscopy is from a remote area only. We are going from a remote incision site.
Ratan, you can please speak up if you want to say something. You are in the panel right now.
Yeah, this is something which we have also done. The size of the incision that we use for retroauricular or infraclavicular, the amount of dissection that you do is much more than what you do in a conventional neck dissection. You can do a selective neck dissection with a 4 to 5 centimeter incision in the neck crease. So when you plan on doing all this robotic neck dissection, so through various approaches, that is retroauricular or axillary or infraclavicular, the amount of tissue dissection that you do is much more than what you do over and above the conventional neck dissection. So call it.
So how will we, Ratan, how are we going to word it in this, for this part?
I think this is, in our country, we should not promote right now. I think KK sir, are you there?
I'm there, Saurabh. I would say it is not routinely recommended.
I think we should. I think you keep it as if then I think Dikru sir is not here and Pankaj sir, because I really think this is an area which is upcoming, but at least I feel the training of head and neck surgeon for robotic is not adequate, unlike other stream. Because
so, sir, that can be mentioned. If a trained surgeon is doing that for indicated cases, then we can consider this. We may put it as may consider. Right. We cannot recommend it, of course.
No, I think
this routine, is there is no routine recommendation of offering minimal or any remote access neck dissection as a standard of care right now. And so we do not have any robust evidence to suggest that, and we have to evaluate the oncological safety in our setup as well.
Oncological and cosmetic safety also. I don't know how much retroauricular neck dissection in males. I want to know the incidence of hypertrophic scars. In males, it is bad. So even cosmesis in males, it is sometimes a problem. So we have to have our own data for what we do.
I completely agree with sir. And this kind of neck dissection, the approaches were started in Korea because culturally they want to avoid scars in the neck. And their skin is different from Indian skin or say in the African skin. So our skin may react badly to these various incisions. We may have hypertrophic scars and all that. So we have to be decide properly whether we should apply this. But it is reasonably safe. It's not that it is unsafe. In safe people who have had extensive experience in this, it's reasonably safe. You can do even if it is N+. That is. Not radiological N+, but even in occult lymph node metastasis, if you send for frozen, you can address the level 5 also with the retroauricular or even the infraclavicular for that matter. It's not difficult to access level 5.
So can we move to the next? What are the real advantages and disadvantages of remote access neck dissection?
Just the scar.
Okay.
Concealed scar. That would be the right word.
So
To hide-
concealed scar.
Other than that, there is no other advantage. You actually do more dissection than what you conventionally do in neck dissection.
I think the other advantage would be lymphedema, which should definitely, because of the horizontal scar and the vertical scar, I think the drainage of the lymphatics would be better. But again, it's not, the evidence is not robust. So I think putting a sentence is not routinely recommended, but can be considered in a trial setting or in a young patient with good prognosis is the right sentence, I suppose.
We'll have to frame the next question like, does a surgeon performing a minimal access or a robotic remote access neck dissection be considered superior? We'll have to reframe this thing. So how do we classify the skills of a remote access compared to a conventional approach surgeon? Ratan, you want to say something?
My only question is how much data we have. Look, whenever we are talking, means we are doing robotic neck dissection, we know, we have seen that the clearance is good by some surgeon. But when we are going to recommend in a data or a guideline, we have to support it with not our individual experience, but with the available data. So how much available data is there which are showing that it is equally good, like the clearance is equally good like our open surgery. So I really think, I don't have idea. We have to go and we have to check. If that type of data is not till date available, we can straight away say that it is in experimental state.
Several prospective and prospective studies, not Indian, of course, but otherwise these are available.
But yeah, Akshat, I'm just, I was just going through literature because I'm in web. So there are 10, 12 patients data. I'm just saying that there is one data with 10 patients. So I really think we have to check how much data, because we have to give that in our guideline. We have to give that. These are the recommendations. So I really think we should come in the next meeting and let's discuss on this aspect. We will come with something. Manish can take the lead in this aspect, and will the come how many patients data are available, what are these, how much prospective data, this, then only we can think about, because we know that people are doing, but we have to, when we are going for a guideline, we have to substantiate it with adequate data.
So we'll definitely discuss upon like replace of conventional approach to the neck in the next 20 years. So we'll discuss upon this point later on.
Definite no, it won't replace conventional approach. This is
Conventional scars are also still okay. It won't replace.
So my point is, let's have the data collection. We will come in the next meeting. Probably, I think, Asim, it's a very good idea. We will go through all this and then make short 1 2 hour meeting subsequent particular topic. Like again, so for that time, everybody will come up with their data like SNB. So what will be exactly written? What will be the literature we are going to quote? Everything has to be discussed in maybe one meeting for that remote access neck dissection. I think it would be better.
Okay, so we'll move on to the next question. Like now with Risha ma'am, is imaging in follow-up essential?
Yeah, Asim, we just need to maybe depending upon the cohort, for early cancers where we have excise the primary and address the neck, their clinical examination may suffice, which should be supplemented with imaging only if there are symptoms. But if it is in the setting where we have given definitive chemoradiotherapy and we have the backup option of doing the salvage surgery, in those cases, we should have intense follow-up probably with a PET scan. So yes.
So and when do you advise to do a PET scan in such cases?
So as data has already shown from the meta-analysis, we know it has to be done 12 or more weeks.
So post completion of treatment, post completion of the adjuvant, you're planning to, will be recommending to do a PET scan post 12 weeks.
Yeah, 12 weeks or more, correct.
And so in cases where we have not done the adjuvant?
Richa, I have a question here. No,
yes,
the
sir.
PET scan recommendations, do we have robust data in oral cavity post-surgery and neck dissection. Can the data from the oropharynx, hypopharynx be extrapolated to our oral cavity tumors?
So that's why I said post definitive radiotherapy or chemoradiotherapy when we have the salvage surgery option in those cases, sir.
So that's what. So no, in a post-surgery adjuvant therapy, can that data be extrapolated to our?
So, sir, in that scenario, we will have two situations when we are dealing with the early oral cancer or advanced oral cancer. When it is the early oral cancer, the clinical examination probably would suffice and the imaging to be done only if the patient is symptomatic. And for locally advanced option, again, if the patient is heavily treated and patient is not having any symptoms, the PET scan at the best would find up only distant metastasis. So again, we would not have much to offer in those cases.
Exactly. That's the point I want to say. The data is only for primary chemoradiotherapy. That is mainly for oropharynx and hypopharynx or larynx, but that may not be fully applicable in an oral cavity situation.
Right, sir.
So for early oral cancers where we have not given adjuvant treatment, clinical examination will suffice for follow-up. And patient without any symptoms, we do not recommend for any routine imaging in the follow-up. In cases of symptomatic patients, we recommend performing a PET scan or a imaging as needed.
Shouldn't we make a recommendation on ultrasound here? I'm not sure. So Richa or any other.
So in routine ultrasound in every follow-up after neck dissection?
Not every follow-up, at least for 3 months or 6 months or whatever. I'm just asking. I'm not sure about this point.
Richa, can you comment on this?
So, sir, if the neck has been addressed, then probably the ultrasound is not going to help us much from our trial. But where the clinical examination is suboptimal, at least the NCCN guidelines say that the ultrasound can be done. So if it is a heavily treated neck and we cannot assess it, and if there is any worrisome finding, then to be complemented. But it doesn't say routinely.
Exactly. I think in that scenario, when there is neck, means neck is not palpable because of radiation, edema and all fibrosis. So in that case, definitely ultrasound has to be done. Otherwise, if it is clinically N0, I don't think it's required routinely for every patient.
So that answers our second question as well, that the best imaging modality for the follow-up. What is the best imaging modality in a follow-up will be?
Post definitive radiotherapy and chemoradiotherapy, it would be a PET scan.
Okay. Now coming to the next question, can a PET scan follow-up help in regulating our follow-up?
For previous question, do we also need to mention any frequency?
Can you elaborate, Akshat, please?
How frequent should, like post chemoradiation, if you are following up, then how frequent should the PET scan be? Like we're saying that neck needs to be assessed by a PET scan. So normally what is done is like we'll probably do it at the first instance and then on clinical suspicion or probably after some time. So do we need to give any frequency for that?
iPhone charger is then I
So,
don't know.
Akshat, regarding that, if your first PET scan, if reported according to the NIRADS is normal, it doesn't warrant a further follow-up. And then based on NIRADS finding, if you have NIRADS 2, then probably you need to repeat it at 6 months.
Okay.
Does it answer?
Anish, you want to say something? And Ratan?
No, I was just telling what Richa said.
If it's NIRADS 2 and above, then definitely a repeat PET scan is going to help.
Yeah, I would just add one thing. There is a trial going on by Hisham Mehana. It's a PET-NEC 2 trial, which is trying to do an annual PET scan, and he is trying to consider whether that can replace follow-up for head neck cancer patient. It's very, it's not, obviously it can't be put in the guidelines, but yeah, what Richa said, I agree with her.
Asim, can I come in, Devendra here?
Yes, sir, please.
So we are concentrating majority of the time on the neck. What is said, I agree with Richa. 8 weeks, 12 weeks, do a PET scan. But PET scan we are forgetting the primary, and sometimes we fail in the primary and we get second primaries. And a PET scan sometimes has a lot of false positives. It will show up some light up, some necrosis here and there, then you're left wondering what to do, then you keep punching it again and again. So I'm not sure whether a PET scan is ideal for primary as well. Neck, yes, the PET neck trial has told us. And then somebody talked about heavily treated neck. The question that we have to ask ourselves is it really important in a heavily treated neck to detect a nodal disease, asymptomatic nodal disease? Because when do you treat because majority of the times it won't be operable. So there are a lot of questions that are being thrown up. You can't do, if you look at most of the studies, majority of the recurrences will come in the interim. You'll never pick up a disease when you do a 3-monthly ultrasound. Very, very rarely. They will come with disease to you in your follow-up and tell you that there is a node, and then you'll do ultrasound and MRI and then pick it up. So really you have to be careful in what we advocate. Yes, we have to do something, and general guidelines is do one imaging in the first 1 year, and that imaging is a baseline for future changes. So if you do an MRI, then that would give you a baseline. So you know what changes are happening when patient becomes symptomatic, and you have to do an MRI, you can compare it with the older one. So we have to really be sure of what we are advocating, because PET scan can have a lot of false positives, especially at the primary in a radiated patient.
Thank you, sir. So just the imaging will not depend upon what we are going to advise only for the neck. It also depends upon what and how the status of the primary is, and what about the symptomatic. So if it is asymptomatic, without any site in the problem in the primary site, and no disease in the primary side, we would not recommend routine imaging in follow-up. And a single imaging modality in the first year is sufficient. Is that okay, sir?
I guess so. For others to comment, because PET sometimes can really give a lot of false positives, and you really don't know what to do. So, and Manish, is that PET neck 2 trial? See, we are concentrating only on the neck, right? We are not looking at the
No, right. It is all head neck cancers, everything.
So primary as well. They're trying to detect primary as well.
Yeah. Because they are saying that the NHS appointments have been clogged up by the follow-up patients, which we see every 2 months.
Exactly my point. Unnecessary PETs. We're doing unnecessary PETs. Maybe one MRI in the first year, and you can write it either ways. You can write a PET CT or an MRI in the first year as a baseline investigation, which can be correlated later when the patient and later investigation when the patient becomes symptomatic or there is a suspicion of another lesion coming up.
So I think I agree with Devendra sir, because PET is not routinely available everywhere as well, actually. So CT, MRI, depending on the primary side, would be also not a bad idea. But we all know that literature favors PET, probably.
So now coming to the next question, which has already been answered, is does imaging system help in regularizing our follow-up protocols? So we do not have a clear-cut answer for this, because the follow-up protocols do not only depend upon the imaging of the neck, it also depends upon the imaging of the primary and also the status of the primary. So we do not recommend any imaging system as of now for regularizing a follow-up protocol. Is it okay with everyone? Disconnect to me.
Okay.
Yeah. Now, how will the practice change in the next 10 years pertaining to the methods we use to follow up? Are we expecting any change based on the recent trials that are going on the worldwide?
Yeah, this
maybe more of imaging
may give some answers.
Can we have some more elaboration on this? Like what imaging would be helpful and how we are going to change the pattern of follow-up? Yes, Ratan.
I think we should, if it is a guideline, we should remove this, right?
Okay.
Or maybe we can just enumerate the landmark trials that are running across the globe. So if we want to mention PET-NEC 2 here or something like that, future research. So we the answer awaits or something like that.
Okay.
That can be done there.
The next, Akshat, you asked about the frequency of neck imaging on follow-up.
Yes, so yes, I think common consensus would be that we do first imaging on, the imaging on first follow-up, and then probably annually or as per clinical suspicion.
I would agree with annually. At first follow-up and then annually once we do it, and if everything is all right, then let it be led or guided by what you call symptoms. Because in most of the you have equivocal evidence in literature, if you ask me. Richa showed things that talked about doing more aggressive follow-ups and then detecting disease early. But at the same time, we do realize that if we have early failures, these are patients who are not going to do well. So my thing would be actually, if you look, and then of course going the molecular way and looking at ctDNA and things like that. But I would think one we should do at follow-up because that will act as the baseline. And then after we should do it annually once after a year, and then let that guide your future imaging. I don't know, because we have to think about our country also.
Ma'am, can we say that if we have a basic or an annual imaging, then based on the symptoms, we may guide our imaging modality on follow-up?
We can do that. We can do that because I don't know what the others feel about it, because it is okay for us to say that do imaging annually, cross-sectional imaging annually. But now supposing you pick up something at 1 year and it is operable versus not operable, how do you distinguish? Things like that also will come into the play, because we also have to look at cost effectivity of doing this annual and regular imaging. So that's why that's my interpretation of the entire data. I know Richard showed us evidence, and we know about evidence that says if you more aggressively follow up patients, you are likely to catch them early. And then, but at the same time, you also have evidence to tell you that even if you catch them, there may not be anything that you could do, because Richard did also show us evidence to say that the overall survival is not going to change.
Okay, ma'am. So now coming to the last, like standardization of a quality of life assessment post-neck dissection. So what guidelines do we follow to standardize the reporting of the quality of life, the reporting of the neck movements, and the reporting of these scenarios in our country, and how we standardize them?
Why we are specifically talking about a quality of life post neck dissection? Can it be post treatment of oral cancer?
I agree with you. It should be post treatment also, no? Because
we had framed this guideline for the neck dissection only, pertaining to neck dissection. So when we combine it with others, then we can say for the oral cancer treatment. But for right now, for post neck dissection, we have to standardize that patients who have undergone neck dissection as compared to patients who have not undergone neck dissection. So how we are going to standardize them?
Not sure about the tools that are available that can specifically look into the quality of life.
There is no comparison also, like there are several couple of shoulder mobility scales available, but we don't know which one is really better.
So morbidity is different from quality of life. So quality of life tools specific for neck dissection, I don't think there are specific. Quality of life comes like an overall treatment specific. So maybe we should reframe the question.
Okay.
So Asim, just one thing. So when we are talking about the quality of life, especially in context to the Indian scenario, we should probably be also considering what is translated and validated in Indian languages and not just the English questionnaire. And to my knowledge, or at least a search that I did for my trial, or with that, we just ended up doing the translation and validation for a neck dissection impairment index. Apart from this URTC and the University of Washington manual, which are general questionnaires for quality of life. So maybe whatever is translated can be used in Indian context.
Okay. So whatever we are proposing for a quality of life assessment, it has to be translatable into various languages And then we also must add a neck dissection impairment index in that, and the impairment caused by neck dissection, and then address this point.
Okay.
Is there any?
Sorry, are we
points?
recommending neck dissection impairment index for everyone? Are we recommending it?
We'll have
Not
to.
recommending it.
We are not recommending.
We are
Please
saying
go ahead.
the questionnaire needs to be translated and validated in Indian languages, and at least NDII is something which is now available in Hindi, will be available because I have finished doing it. We are doing the analysis and we'll publish it now. So we would be ready with in Hindi and Marathi. So if we have any other that has been translated to other Indian languages, can also be recommended in the list, but we need to translate and validate in Indian languages.
Okay.
So I think we have come to the end, but there will be several other points that will be coming up as we'll be framing the questions. So if there are any more questions, there will be definitely more questions. So subsequently, we'll plan in next 3 to 4 weeks time another meeting where we'll be discussing all those points that we discussed today, complete them, and then come up with a draft of the consensus.
Thank you.
And I thank everyone for joining today. Thank you, Devendra sir. Thank you, Krishna Kumar sir. Thank you, Sajid sir, Richa madam, Sarbani ma'am. Thank you, Ratan. Thank you, Apurv, and thank you, Saurav sir. And thanks all the participants. Thank you, everyone.
Thank you, everyone.
Thank you. Bye-bye.
Bye. Bye.